so I'll diwrnod o Cyfarfod Bwrdd arbennig. Good morning, everybody, and welcome to the second day of our special board meeting. Thank you for coming back. Yesterday was a fairly lengthy day, and we took a long time to consider the details of the clinical service plan. And this morning, we are going to reach some decisions in terms of how we think we should move forward in relation to the options. Welcome to those who've joined as part of our audience. We hope that you'll be suitably engaged in proceedings as they occur this morning, and it will provide you with some reassurance that what we are trying to do is ensure that we take a measured, considered and thoughtful approach to how we address the future development of services across the Health Board. I'm not going to rehearse what we said yesterday morning, but just to remind people of a few things that the team will lead this morning in terms of summarised reiteration of where we got to yesterday. I think from my perspective, I'd just like to reinforce those key issues that we do at every board meeting, which is when we make decisions, we do so on the basis of a number of core design decision-making principles. Those principles is largely to ensure that our decisions are always fair, they're affordable and sustainable, they're consistent with our strategy and our long-term vision of what we want to generate for the board. They don't create an unhelpful precedent, and perhaps most importantly of all, they are safe. So the decisions we make lead to safe patient outcomes in terms of some of the services that we're trying to develop and take forward. I think that's probably critical in terms of our thinking. I'm not going to say a great deal more at this stage because I know the team will want to spend some time sharing their reflections on yesterday. There is a rhythm to today. So we will look at each of the 9 services in probably 3 sections, and we will take a break at various points to make sure that we are bringing our best to each of those considerations and that we're not wearing ourselves out during the course of the morning. So we will break regularly as we hear it. We've set aside enough time to consider and think about those options. It is, as I've already indicated, not a rehearsal of yesterday, so we're not going back to rehearse what we've already heard. I'm hoping that overnight board members perhaps would have reflected further and may have some additional insight they would want to bring to the discussion, but largely what we need to do is stay focused on taking pragmatic action in terms of choosing which option we think is appropriate. Having said that, I'm going to hand over to Lee.
Diolch, Cadeirydd. Thank you, Chair. So, just by way of brief introduction, I thought I'd give a high-level overview of what I think we heard yesterday, and then I'll ask the team to take us through the decision-making framework that we've got for today ahead of going into each of the relevant service areas. So, yesterday we split the day into a number of sections. So we started off by hearing about the process that we followed. My summary of that would be that we've followed a detailed, methodical and open process to consider the issues across the 9 services that we have, develop options and then test them with our population. We received independent assurance on that as a board on the process. We also received a detailed consultation report describing the findings from the consultation. Over 4,000 people attended engagement events and we received over 4,000 questionnaires. From those questionnaires, we were able to identify a number of key themes to support our decision making, and we also sought alternative options and ideas that could be considered as part of this decision making process. So from the consultation we received nearly 200 of those alternative ideas, and 22 of them have made it into the options that we considered yesterday. From an acute services point of view, we looked at 3 services, emergency general surgery, critical care and stroke. What we heard from our clinicians and service leads was that those services have become more specialist in their nature over the last decade or two. That has enabled better outcomes for patients, high standards, but generally that means it's delivered in fewer locations. That presents a challenge for us as a health board that provides services over a large rural area and has generally smaller units, and we need to factor that into our decision making. The numbers of patients affected by those services can be quite small compared to some of the other services that we're considering, but the impact is very significant, and we've certainly heard that through the consultation. What we were recognising was that our population do not currently benefit from the advancements in standards that we have seen across the rest of the UK and the world. And we need to think about how our future configuration will set the foundations for us to be in a position to deliver those standards in the future. It was also noted that it will be difficult for us to recruit consultants and specialist workforce in these areas if we're not in a position where we can deliver the modern standards of care. So, whilst there are a lot of concerns around the current position, and we're recognising that our services are not where we want them to be, this does present us with an opportunity today. The flip side of that is an opportunity where we can take decisions which will improve outcomes and secure the long-term future of those services in West Wales. From a planned care point of view, we've got a different set of challenges. So there are some areas with workforce challenges and fragilities, particularly in areas such as dermatology, but often the challenge is more about the waiting times and the delivery of enough activity to meet the needs of our population in a timely fashion. We've seen through the course of the clinical services plan work that we've delivered improvements in waiting times in a number of areas, but nonetheless the waiting times remain longer than we would want for ourselves and our family. We've seen temporary service changes since COVID in a number of services, and part of the decision making through the course of today will allow us to determine the permanent arrangements for those services. Given the nature of the challenges within planned care, productivity and efficiency of the services becomes a very important consideration for us in our decision making today. In particular, to reduce and eliminate ultimately unsustainable and ad hoc solutions to delivering activity. From a diagnostics point of view, we heard about endoscopy and radiology. These services are critical to a range of pathways beyond the services themselves. They do present with a different set of challenges, so they're not fragile in the same way that we've seen with some of the other services, but and their activity is measured in the thousands, not in single figures. What we've seen again is some improvement in waiting times over the course of the clinical services plan work, but what we're also seeing is significant demand growth in those two services over many years and projected into the future, and therefore our considerations need to be around how we might set our services up to meet those future demands in the future to ensure that we can deliver timely care across all the pathways that those services support. Thank you, Chair. I'll invite Ben to come in, but I don't know whether you want to pause at that point and check.
Thank you. That was very helpful, and in terms of an overview of where we kind of got to yesterday. I'm not going to open it up for comments because we'll end up in a discussion that is probably unhelpful at this stage. Ben.
Thank you, Mr. Chair. Just to go on to the slides then, that will hopefully pop up onto the screen now. One moment. Thank you. Yesterday, and building up to yesterday, you'll have drawn on the key programme materials that were shown on the screen there, that were produced post the consultation, as well as analysis made during phase 2 of the clinical services plan programme. The information you've considered includes the independent consultation report from Opinion Research Services, the alternative options previously shared with our Strategy and Planning Committee, and the findings from our Quality, Safety and Experience extraordinary sessions, the informing plan and the process of the conscientious consideration that you went through. In addition to that, on the next slide, you'll see information that brings those reports together in terms of the phase 3 closing report, the outputs, including the alternative options appraisal, and the shortlisting workshops we went through. It's supported by updated programme impact assessments covering equality, health, equality, quality and environment, as well as the capital, workforce and financial indicative estimates that underpin some of the evaluation criteria for the programme. Together with today's materials, these represent only the top layer of our information pyramid, and we would encourage anyone with a specific or specialist interest in these services discussed to explore those documents further as a baseline. We'd also like to thank Q Irwin & Co. Associates who are providing quality assurance based on the Centre for Consultation framework within our plan. Bringing us forward to today then, and into the decision-making framework, we just wanted to recover back with you a decision that was made in board in November 2024. And on the screen you will see how options can be delivered in a sustainable way that resolves the issues, yet also recognises the limiting factors that may need further work, such as additional funding or longer-term programmes of work. It supports resolving pressing issues or mandates for change in a timely manner, whilst also recognising the Health Board's routine business case process to support detailed analysis in the next phase of our programme planning. Okay, so as you'll see in this, we're looking at 3 phases, as you'll reflect from yesterday's, as we presented the services and as we will do today. That implementation phase looks at how do we manage those current issues and challenges. That improvement phase mandates for those medium-term changes or sustainability items, and those longer-term items that might be things that are more strategic for us as a health board, that might take longer pieces of work for us to get to. And there are timelines associated with those as well. Okay. I'd like to hand over to Alex now around our decision-making outcomes for today.
Alex.
So normally when we bring decisions to board for service change, we'd have a report with recommendations around options potentially. We're slightly different with the clinical services plan, that there's 9 services. And actually what you'll see today is the considerations from yesterday. And actually what we're asking the board is to make one of 3 decisions potentially. So we have 48 options that we'll be asking you to look at. And what we're suggesting is that you may want to make a decision, so you feel confident as a board that you've had enough information from the programme and that the options respond to what you heard during the consultation, and that you feel that we can move forward and begin the implementation of that. It could be that you've heard from the consultation, you feel that the options do respond to what the public told you during the consultation, but recognising that, as we heard, the workforce and the finance assessments, they're indicative at this stage because we are looking at so many options. So it may be that you've identified that there is a preferred direction of travel that you want us to explore further and bring that detail back to you before you make that final decision, so that you can have that assurance around what would this mean for our workforce, what this could mean for transport, what this could mean for safety, before you make that final decision. And then lastly, we're asking around a pre-provisional decision. So we know that we shared some ideas yesterday and options that were not fully tested during the consultation. They came from the consultation, they respond to the issues, but actually they may have impacts that are yet unknown for members of our communities. And actually we may need to go back out and test those through a targeted piece of engagement. So I was going to, at this point, bring in Kathy Graham briefly just around what that could mean.
So I just want to...
Kathy, pull the microphone to you.
Thank you. Sorry, Chair. So I just want to kind of go back to first principles here and just remind you about the purpose of consultation. Yes, it's a statutory requirement, but really this is your opportunity to gather additional intelligence from our public. The information that has been provided to the public has provided them the opportunity to provide their informed views on the options. The questions were framed in such a way that the public were able to explain to you the benefits of the various options put out, impacts, mitigations, as well as the opportunity to come up with their own options. So it has been a really thorough evidence gathering exercise. So within that, so the purpose is to build on your existing knowledge base to help you make the best decision possible. So where there has been alternative options presented and those have gone through the same options appraisal as the original options that were consulted upon, and where those options have actually enhanced perhaps proposals, it would be our recommendation, our view, that that is not something you would need to go out and re-engage or consult upon, because the purpose of the consultation has been fulfilled. The public have told you something that would be even more beneficial. There may also be instances where communities, people, stakeholders have told you actually there are other impacts, but you in your decision making may come up with mitigations to help address those. And again, in implementing the option, then there may not be a need for further engagement. I think that it's important to remember that you, as the board, you do have the ability to make these decisions, and that sometimes what may happen is you get stuck in a consultation loop. There has to be a point in time where you feel that you have the evidence, you have the information, you are able to mitigate impacts and move on with that decision. I think Lee has very clearly set out the fact that this has been a planned approach. It has been an engaged approach to allow you to make those decisions, to allow this change to happen in a planned manner. We hear so often about change by collapse, and this certainly isn't that. You're taking on board all the information, and Ben has also set out about that information pyramid, and we really reviewed the information that was out there in the public domain and the level of detail and technical documents that the public were signposted to. Should anybody have wanted that further information, gave them that ability to provide their informed views.
Thank you, Cathy. Can I ask, for the sake of our members of the public who are here, that you introduce yourself?
Sorry, yes. So my name is Cathy Graham, and I am an expert on public consultation process and design. So I work with an organisation called HYCO and also the Centre for Consultation. So we have applied a quality assurance framework for the end-to-end consultation process that the board have implemented.
Thank you very much for the clarity that you've offered us in terms of understanding the consultation process and what we might need to do as part of the next stage. Suki, can I ask you to introduce yourself as well? You will need to pull the microphone to you. Yep.
Hi, I'm Suchi Vijay. I work as a GP. I also work as a program director for GP training in Pembrokeshire. So I'm wearing various hats at this point. I do a bit of LMC work as well. So I think I'll be getting, you will be getting a view from the GP colleagues of mine and probably mine as well. Thank you.
Just to clarify, Suki's here to observe this board today in terms of how we make decisions. You're very welcome. Thank you. Okay.
So before we head into the options consideration for the rest of this session, I just wanted to recap really on how the decisions that are made today will be reflected in future delivery. So what we're not expecting is any of these changes to materially impact the annual plan for next year. So that's because depending on the decision made and the additional work we have to do, it would be too late to put in the next year annual plan. What we are expecting is to see those potentially the work to deliver some of these options appear in that plan, but the outcomes of that may not be delivered until the 27-28 planning process onwards. I think the other important bit about that is yesterday you heard a lot from the services about the hard work they've been putting in recently to help tackle backlogs through things like waiting list initiatives. And that's also been largely as a result of goodwill to do that as well, and they reflected that wasn't sustainable. What you see in these options that they put forward, and the alternative options as well, is what they believe to be a way to sustain those gains. so that they can sustainably continue to deliver services and not need to bring in that additional work to do that. So that would be something, again, we would expect to see in future annual plans, that we're able to manage those waiting lists within our services without needing to look for additional workforce and additional asks from our teams. And then I thought it'd be useful at this point just to recap around the top 3 criteria that we had yesterday. So the options that were presented, they looked at the scoring as part of the option development group. And the top 3 criteria that the options responded to were clinically sustainable. So would there be a need for that service? Would there be enough patients to actually make that a viable service? Workforce sustainability. So would we be able to sustainably recruit the staff to make sure that that service lasts and that we wouldn't be in a position where we have to come back and look at doing this sort of thing again? And then lastly, compliance and attainment of standards. So would we, by making these changes, improve the standard and quality of care that we're able to provide? So when you see the options later, it's just worth remembering that that's what these options have been assessed as doing well against, and that's why they've been put forward. But that doesn't mean that you can only pick those ones that you see on the screen. We did share 48 options with you yesterday. If you think that there are actually other options there that you want to consider, that this doesn't preclude that.
Thank you. Very helpful.
So this slide highlights the key considerations that you heard yesterday from the public consultation feedback and the service dependencies for emergency general surgery, critical care and stroke. Some of the key considerations are transport and transfer of patients, transport and travel for patient visitors, impact on the Welsh language as considered through our quality impact assessments, and regional working.
Okay, thank you for that. I'm minded that throughout throughout yesterday, when we received that kind of feedback, Nikki gave us the feedback from the consultation and the views of the communities. The transport and travel was a recurrent theme. On every occasion, it was a recurrent theme. So and we had a very helpful suggestion from Alison Kleiss, who suggested that we need to think about this strategically. So we need to start to build a transport and travel plan and transfer plan that's strategically driven. And I think what we need to do is understand that when we think about some of these decisions is in the context of needing to build that strategic approach to transfer and travel and transport, that we need to be clear. To understand the distinction between those two, transfer is between hospitals, so fundamentally within our gift and the way in which we operate. Transport is another issue. It's much more systemic. It's not within our gift. Some of it is, but some of it isn't. So that will require us to think differently about how we work with our partners and other parties to be able to develop that coherent, complementary approach to developing that, which may take more time in the order of things. But I think that distinction is really important. Great. Okay. So shall we move to the options for consideration? So in terms of emergency general surgery, we had option for option A, which was a kind of 0 to 2 year option. Option B, which is our improvement option, which is 155, and that was an option that was introduced by throughout the consultation process and the involvement of the public, and a longer term option aligned to our broader work, option 222. So in terms of those options, I'm presuming those are all the ones we're considering in relation to, just to confirm, emergency general surgery. Yep. I want to invite views or thoughts. Mark.
So I'll give the clinical view, and I'll give the view of somebody who's worked in the Emergency General Surgical Service in Hywel Dda for 20 years. Even since the inception of the Health Board, there has been disparity in general surgery because of the configuration of our services. The option presented here for implementation, option A, does really give us the best option for providing a quality, safe and sustainable service, I think, for the future. It will allow us to provide a sustainable rota, allow us to further specialise, and importantly for our patients, ensure that there is equity of service for all of our patients, that they're all offered the highest standard of general surgical care. I would very much commend the options as they are described. And then the improvement phase, which indicates strengthening the same-day emergency care, also will ensure that the majority of patients are assessed as close to home as possible, and the smallest number of patients will require transfer or transport to Glangwili Hospital. And we do know that patients will recover better from particularly major surgery if they're offered high-quality rehabilitation. So then the longer term of developing rehabilitation units in line with our other services will ensure that we deliver the best outcomes for our patients.
Okay, thank you very much. So back to Alex's reference to those three levels the 2 levels of sustainability, workforce and the highest kind of clinical practice, but also meeting standards. In your view, it would
achieve that, yes.
It would meet those 3 factors. Andrew, anything you'd want to add in terms of the way these services are operated?
No, I think I would echo a lot of what Mark has just said as medical director. I think what we do know and what we've heard is that I think the model as described will retain as much activity as possible in Withybush. I mean, only the very specialist cases that needs potential surgery will move, so it mitigates the impact whilst protecting care as close to home as possible. And certainly we know and we heard how challenging it is increasingly to staff multiple on-call rotas out of hours across multiple sites. So this would help address that issue and make it a more attractive service in which colleagues from across the UK would
to recruit
to. Yeah. So I'd agree with everything Mark said.
Thank you very much. Hugh, and then I'm going to go to Sharon, and I'll come to Phil.
Yeah, thank you. I'll just make a couple of observations in Welsh. Fi'n cytuno gyda'r y cam a'r cyfeiriad sydd yn cael ei annog. Dim ond moyn bod yn glir I fi fod dal angen I ni cael achos busnes I ddod nôl i'r bwrdd ynglyn â buddsoddi yn y gwelliannau bydd angen ac yn yr hir dymor, felly opsiwn 155 ac opsiwn 222. Felly mae hwn yn rhoi cyfeiriad cryf I ni, ond bydd dal angen achos busnes sydd yn ôl yn y dyfodol.
Diolch. Thank you, Hugh. Very helpful. Sharon.
Chair, are you able to hear me?
We can't see you, but we can hear you.
Oh, thank you.
Actually,
I just wanted...
We can see you now. Go ahead.
You can see me. Excellent. Thank you. You will have heard mentioned over the last, yesterday and potentially today, around the quality impact assessments. And I just wanted to assure Board that in line with the Health and Social Care Quality and Engagement Act, the Health Board is required to demonstrate that all strategic decisions are informed by the duty of quality, ensuring that an improvement across the 6 statutory domains of quality, namely safe, effective, efficient, equitable, timely and person-centred. So just to fulfil that obligation, a full quality impact assessment has been undertaken for every shortlisted option across all 9 services within the clinical services plan. And this will provide the Board with a structured, evidence-based understanding of the anticipated impact of each configuration prior to determining the preferred service model. So across all the services, the quality impact assessment process confirmed that the clinical services plan represents a critical opportunity to address long-standing fragilities, work for sustainability challenges and variations in service delivery and inequity of access. So I would just like to, in terms of emergency general surgery, the centralised emergency general surgery model, the option A and option 155 quality impact assessment, confirmed that offered improved shorter robustness, reduced reliance on locums and safer, more consistent pathways supported by the expanded same-day emergency care provision. Thank you, Chair.
Diolch. Thank you, Sharon. I'm going to come to Lisa. Michael, do you want to say anything?
The question of clarification I want to ask.
Do you want to?
Clarification question.
Yeah.
In terms of option A, we're moving emergency services out, general surgery out of Withybush, yeah, or it won't be in Withybush. If I was the Pembrokeshire resident, where would I rehab after my emergency surgery in Glangwili, for example? Where would I rehab?
So I know it's wording, but we're not moving emergency general surgery out of Withybush. The patients that will move will be those requiring surgery or that need assessment by a specialist surgeon that is only in Glangwili. So currently rehabilitation is performed either in the local hospital, so a degree of early rehabilitation will be undertaken in Glangwili, and then a proportion of patients may return to Withybush, may return to the community, or may return home. So those pathways are in place now, so we're not looking to disturb any of those. And I think the numbers of patients would be small.
As in?
As in a low number of patients that would need to do that.
As in? We've
as
said
in,
small,
I would say probably less than one a week.
Okay, thank you. That's helpful. Maynard, you look inquisitive. Is there anything you want to say?
I was just going to comment that the numbers are actually, we did hear yesterday.
We did.
Currently, it would be a maximum of 9, but they would anticipate that declining because of the aesthetic services.
Of course.
Quite substantially. So.
And I think Andrew pointed out more delivered through primary care and other services.
Those 9 patients are the patients who are having inpatient emergency surgery at the moment. And the majority of those will not need rehabilitation. In Withybush currently, there is 1 patient a week who has a major emergency abdominal operation. So those are the patients that likely do need some form of rehabilitation afterwards.
Great, thank you, very helpful. Lisa, and then I'm going to go to Phil, and then I think there's 2 other people now.
Thank you, Chair. So the different options that we have here have different workforce requirements. We've been able to undertake an assessment around what we think are the medical and nursing requirements. However, there is further work that would need to be done around therapy input into some of those particular areas. So there is further work that we would need to do through a workforce plan for those 3 options.
Okay, so I suspect, and that's partly linked to that implementation period. There is other things we need to do before we can move forward. And as I said yesterday, what we do as a board, we endorse this direction of travel. We think this is the right thing to do, but the practicalities and the operationalisation of that will need to follow afterwards. Thank you. Chantal and then Neil.
Diolch, Chair. I just wondered whether it would be worth restating what we actually mean by strengthening SDEC. Because when you look at the options, in particular in terms of Withybush, we do say no emergency general surgery, but strengthening SDEC or same-day emergency consultation. I just wondered whether we should restate what we actually mean by that.
Okay, I'm going to hold on to that one, Mark. I'm going to go to Neil first and then come back. Neil.
Thank you. My comments were going to be in the context of all the decisions that we have to make today, actually, if that's okay. Feels like this is an appropriate time. So my reflections overnight were that the question I was asking myself was, what's the deal here? So by that I mean the population, to some extent, to a great extent, want everything everywhere, which has been kind of the model. That's no longer sustainable. And the prevailing narrative, both politically and through the media, has been about loss, not future focus. And so the bit that I'm interested in, to sit here as a Pembrokeshire resident and potentially be deciding to, in theory, perpetuate that story of loss, it sits heavily with me. But my belief is that the future focus about providing safe healthcare services has to change. So I think there's something in this for me with all of these decisions, which is about we're asking the population to trust us. Over the next couple of years, we're going to start to make some changes that will then be implemented with a longer term view on how the world has changed, which you clearly articulated yesterday. So I think in making these decisions, we have a real responsibility to start to tell a different story about a future focus, about what this means for safe healthcare. I think we've got a responsibility to get some of the basics right that the people would naturally call out about missed appointments and just doing the basic things right, which builds trust. And I think part of the deal for me is also about working more with communities and with individuals to help articulate this story that health is not just about what happens when you go to the hospital. It's about what you can do for yourselves in your communities, bearing in mind some of the comments around inequities that we heard yesterday. So I think I just wanted to, looking at the options, my preference would be for 155 out of these two, but I think I'm going to struggle to take each decision individually without considering them in the round, as we heard yesterday, around the interdependencies of the other decisions that we're taking. So I'll probably come back to this a few times, but for me, there's something here about telling the accurate story of why the change is needed and what the deal might be. Thank you.
Thank you, Neil. Before I come to Mark, I would completely agree with what you've just said. And as I said yesterday, we have a responsibility as a board. We have a statutory responsibility. I think we have a moral responsibility. The statutory responsibility is to not knowingly deliver services that are suboptimal or do not meet the standards. If we know there are standards and we're not meeting them, then we are not discharging our role effectively as a board. So fundamentally, that's a very clear message that we need to hold on to as a board. Morally, there's a broader question about what's the right thing to do in this environment. And in my head, it often feels there's a difference between what's the right decision and the good decision. They don't often align. Sometimes they separate. And I think some of our decisions focus in that space. But nevertheless, we have a responsibility to think about the future. It isn't just our job here and now today. We have a responsibility to think about how those services will develop and thrive and prosper in the future to meet the needs of our communities. And I think that's partly what we're doing here. We're trying to not just think about how do we address the fragility of these services. As Sharon has indicated, we do need to make changes in this space. What we're also trying to do is understand what the world will be like in the future and how we will need to deliver for very different demands that emerge from our population in West Wales. So a combination of those things makes it really tricky and really complex for us to work out the solution. But we have to be mindful of all these factors in discharging our role as board members. And frankly, to be a bit courageous inside that space, because actually we do need courage, because we won't please everybody inside this space. We have to do what we think is the right thing to do. Right, I'll get off my soapbox now. I'm going to go to Mark, Eleanor, and then Phil, and then we'll make a decision. Okay.
Okay, I'll answer Chantal's question about what a strengthened SDEC is. Essentially, it's about delivering what our patients need. Patients need access to rapid assessment as close to home as possible, and that's what same-day emergency care is. And what strengthening the service gives us an opportunity to do is to give patients appointments. As what happens now is often patients attend hospital in a relatively unplanned way. We can also align their requirements in terms of the diagnostics they need, so they have the appropriate diagnostics the same day when they attend hospital. They will not need to return unless they need to return for something specific. That means they can leave hospital that day with a diagnosis, a treatment plan, and understanding what their follow-up, if necessary, is going to be. We can looking at the demand and capacity needs for the Pembrokeshire population. I think we can very straightforwardly do that. There is an excellent medical SDEC in Withybush currently, which provides, I'm sure you've all heard, a very high standard of care, and we are providing a lot of surgical assessment currently through that unit. So with some changes and improvements, we can increase the offer to the surgical patients, as I said, with the goal of ensuring that only those patients who really need to travel to Glangwili will do so.
Yeah. Thank you, Mark. Very helpful. Right, I'm conscious of time, so I'm going to ask board members to be succinct, which you always are anyway, Eleanor. So,
I'm mindful that we are of our communities, not just of the board.
Pull the microphone to you a bit more.
I'm mindful that we are part of our community, not just part of the board. What we have to do is to provide the best quality service at the right place at the right time for the people who we are here to serve. That means whether it's in Aberystwyth, in Haverfordwest, in Llanelli, or anywhere in between. And I think we have to listen to our clinicians. Our hospitals are 70 years old, I think, at their oldest. Our demographic is changing. The whole makeup of the population is changing. It is going to take courageous decisions to make this happen, and our clinicians are being courageous and saying our service isn't good enough at the moment. And as a board, we need to be mindful of that and mindful of the fact that people need the best quality service, and that will be the context in which I consider everything that's before me today, and I think that will be the same for every board member as well. Diolch, Cadeirydd.
Thank you, Eleanor. I think that builds on Neil's points about how we need to make our decision. Right, okay. You look as if you want to come in. Ardiana first, and then we'll come to Lee.
Diolch, thank you. As a follow-on from Neil's helpful comments, I wanted to ask the board that where we're looking at all these options, the 9 options, we are also mindful of the provision of not just the health services, but also the health improvement pathways that we have, starting from, as we wrap around, particularly as we're talking from the emergency care services, as we wrap around the social model for health, as we work with our partners to enable our individuals and communities to maintain good health and improve their health. And those aspects throughout the pathway and throughout the 9 services, as we've heard, emergency care, preventable elements of presentation, but also outcomes and recovery from emergency surgery are much better when we have healthier overall in the baseline communities and individuals. From chronic conditions, as we examined yesterday, the bulk of those chronic conditions, stroke, dermatology, urology, are that can be at large preventable, and that we've got those pathways, and as we examine these services, we do not lose sight of including and embedding those preventative interventions. My second point is that we do maintain that equity lens, as Sharon reminded us, for the quality, the act and the assessments that have been done, that we do not forget of the socioeconomic backgrounds of our individuals, not just strictly defined quality, but the equity, that we ensure that when we develop those services, we look at where our individuals, where our patients, where our communities are starting from, not what they're presenting. Because a same clinical intervention does not result in equal outcomes. it can exacerbate inequalities if we do not take account of where our patients and our communities are starting from. And thirdly, and I want to assure but also ask the board that we will monitor outcomes. We are developing better mechanisms of monitoring actual outcomes of our services. And the direction of travel that we'll be setting today, it's not set in stone. We will be reviewing and we will be adopting as needed. Diolch yn fawr. Thank you.
You make a really important point there, Diana, which is that it's not about putting into motion these things and just letting them go. We need to continually be vigilant about the patient experience and how we're improving it. So, and that will mean that in the future we will need to iterate and rethink those services and evolve them and develop them further as we would expect. But thank you very much for that. Very helpful. Lee, and then Hugh, and then the last comment going to Phil.
Okay, so just briefly then. So what we're trying to do through each of these services and decision making is set the direction of travel, and that naturally will fall in some cases into an implementation phase where we seek to resolve the most immediate issues, an improvement phase, and then the longer term. So I'm certainly of the view, as others are, that option A is the best option to deal with the most immediate issues. We would aspire to, as Neil says, option 155, and that obviously enhances the services. And that will be something that we should look to deliver as part of the improvement phase. And then finally, longer term, we have set out a strategic direction for health services in West Wales already. 222 is the one that best aligns with that strategic direction, i.e. that we'd have 2 sites within Hywel Dda delivering emergency general surgery. But at this point, that is not something we can implement. I think we should be noting as a board that would be the direction of travel that we would endorse. But if we were to implement that in the future, then we would need to have a further period of engagement with the population as well, because that would be a different service model to that which we've consulted on. But that is for the future rather than in relation to option A.
That was very helpful as a clarification. Hugh.
Cadeirydd, diolch. Mae Lee wedi wneud y pwynt yn uniongyrchol yn glir. Ond, fel nath Neil gweud yn gynnar, licen ni gweud rhywbeth ar y dechrau sydd yn addas ar gyfer y diwrnod I gyd. A hoffwn ni ailadrodd yn neges ddo a bod yn gwbl glir ynglyn â beth i'n ni'n wneud heddi a beth dyn ni ddim. Dyn ni ddim heddi yn wneud arbedion. Dim hynny yw'r rheswm pan mynd ni'n cael y cyfarfod yma, rhesymau bregysrwydd, creu gwasanaethau cynaladwy a safonau clinigol. Ond mae da ni ddyletswydd i'r trefthalwr hefyd. Os byddwn ni'n gadael gwasanaethau mewn ffyrdd fel maen nhw ar hyn o bryd, bydden nhw'n fregus yn glinigol, yn ddibynnol ar nifel fach o unigolion, a'n cael un anodd I gyrraedd safonau. Wrth gwrs, mae'r canlyniadau ariannol yn dilyn o hynny. I ni'n gwybod fod canlyniadau gwael yn ddrud, bod gwasanaethau annibynnadwy yn ddrud, a bod dyblygu rotas bregus yn ddrud. Felly, bod goblygiadau ariannol ym mhob opsiwn, y ffordd gywir o ddarllen hyn yn nhib I yw y ffordd arall rownd. Os byddwn ni'n dylunio gwasanaethau sy'n gynaladwy, sy'n cyrraedd y safonau'n gyson, sy'n lleihau amrywiad, wedyn mae'r canlyniadau a mae'r bydd ariannol yn dilyn. Ac wrth gwrs, mae yna ddifidend sydd ddim yn y ffigurau o'n blaenau ni heddi. Mae yna ddifidend ariannol mewn canlyniadau gwell. A mae hynny'n galluogi ni yn y dyfodol i'r ryddhau, mae'n rhoi'r rhyddid I ni, I ryddhau a buddsoddi mwy yn y dyfodol I wella gwasanaethau ymhellach. Felly, fel wedodd Lee, mae hwn yn rhoi cyfeiriad cryf I ni, a mae angen I ni ddod nôl wedyn achos busnes sy'n galluogi ni I fuddsoddi mewn gwelliannau yn y cyfeiriad hynny yn y dyfodol. Diolch, Cadeirydd.
Diolch, Hugh. Thank you very much. Phil.
Diolch, Cadeirydd. So I think we did hear yesterday that these are really major procedures that we're talking about here, major surgical procedures from our clinicians. And as our colleagues have said, our clinicians are not satisfied with the standards that we are able to, of care that we're able to provide. They want to improve on the quality. So I found it was helpful to hear that yesterday. And this was all about improving quality and experience for our public in terms of thinking about what the offer is that Neil was asking. We would be looking to that, and we would want to see that in our evaluation as we go forward, as Ardiana was saying. We also want to keep people as local as possible, as many people being treated as locally as possible, which is why the idea of keeping the SDECs in place is important, and keeping the services in Bronglais for people who live in the Mid Wales region. We did hear from the public in Pembrokeshire that they would prefer option B yesterday, but we also heard the concerns from both our clinicians and our managers about the risk of having a on-call that rotated between Withybush and Glangwili. We also heard that that would not only be a clinical risk, it would be a logistical operational risk, and it was also threatened sustainability in terms of recruitment. So there were many things, I think, to be concerned about option B, adding strength, I think, to the options that we're presented with today. My feeling, therefore, is that I agree with colleagues that we're agreeing a direction of travel today with our decisions. We will need a business case, an implementation plan to come back to us, which would need to consider the workforce considerations that Lisa has mentioned, and of course the financial considerations that Hugh has mentioned. And I think also be clear on the outcomes and experience measures that we will be measuring going forwards. Lee mentioned an important point, that as part of our thinking going forwards, we will also need to consider in the longer term options whether there might be a need for future engagement with the public, where there are options that are outside what we've already engaged. And I think probably, as Lee has pointed out, probably option 222 fits into that group.
Great, okay, thank you for that. I'm keen that we make a decision in relation to this service. Mark has indicated that the clinical perspective would be around option A. Can I ask board members what their view would be?
I would agree with Mark, option A.
Everybody's appropriately nodding.
We would like option 155. It's just that it would take longer to put that into place.
I agree with you. I agree with you, and I really think SDECs is part of our stretch into primary care in some strange kind of way. I think they're a pathway towards moving more out of the conventional secondary care environment. So it is consistent with our broad strategic approach to think about how we strengthen and develop those same-day emergency care facilities. But for the sake of this particular decision, I would confirm on the basis of the nods and the yeses around the table that we support option A in relation to emergency general surgery. Okay. Do you feel you need to say something else?
Well, I'm just checking. Are we, as a board, I'm just testing, we're supporting option A for implementation. Are we supporting 115 for improvement, which would also have to be part of the business scan development, and also a strategic aim for option 222, subject to further development and potentially engagement?
So it feels to me we can agree to the improvement, 2 to 4 year improvement, which would result in strengthening the SDEC at Bwrdd, without needing to go back to engagement or consultation. So I think we should embrace that as our aspiration in relation to this. On the longer term view, 222, I think we should just come back to that at the appropriate time. because that will, all kinds of things might change between now and then to influence that. Let's not hold ourselves to that at this point. Are people comfortable with that? Hugh?
Ie, Cadeirydd, fi'n credu bod yn resymol iawn i'r bwrdd i gytuno ar opsiwn A wedyn gofyn i'r executive i ddod nôl a achos busnes ar gyfer 155 a 222 yn y dyfodol.
Of course. So there is a contingency around this. As you've quite rightly pointed out, we're agreeing the direction of travel, but in terms of the supporting business case for this work, then we will have to come back to board. Great, okay. Thank you for that. Let's move to our next service. Could we have it on screen, please? Great. Anything you want to say?
It was just to add, Mr. Chair, that just to reflect on the option, just for everyone's memories, current service as it's currently operating for critical care, we have three intensive, technically we have 4 intensive care units now, but we have a temporary arrangement in place at our Prince Philip site. Within the options, you'll see option 246 featuring for implementation and improvement, and that looks at the development of an enhanced care unit at the Prince Philip site. Going around, you heard the details yesterday from the clinicians around that and the service that would include initial implementation around a consultant anaesthetist to support the enhanced care unit at the site, to support the procedures that are being delivered there. In the improvement phase, that was more around the ICA licences and using aspects of rural GPICs, the general practice on intensive care medicine guidelines, to look to how we could have a sustainable across-site critical care service that supports units in such as Bronglice and Withybush. And the longer term there, you have the option A, again, very similar to 222, being more strategically aligned to maybe changes of having 2 critical care units in the health board. That's okay.
Thank you. That was very helpful. Mark?
Dear Cadet, so I would endorse the options as they've been described. The earliest driver for change was the urgent change that we needed to introduce in Prince Philip Hospital because of our inability to provide safe senior cover to the intensive care unit at Prince Philip Hospital. That still exists, so we do need to make a decision on the future of that. An enhanced care unit will stabilise that situation, allow us to still provide an acute medical take in Prince Philip, and also allow us to provide planned care operations as we do now. In terms of the health board wide service, that has always been a desire, but I think this gives us a direction and supports us developing business cases of how we can do that. There will need to be some technological and digital investment to ensure that we can use telemedicine, for example, between our sites and strengthen the links between the sites. So I think a health board wide intensive care service is something that we absolutely need to do. And as we've described, the longer term model will depend on various issues that we will need to resolve as we go forward. But until that time, then we will need to have, I think, option 246.
Okay, and that's an option generated through our consultation process with our communities. Yeah. Okay, fine. Andrew, anything you'd want to add?
I think only just to emphasise what Mark has said, which is obviously, and I think what Ben touched on, which is we've obviously had a temporary change in place for a number of years now. I think making a decision to formalise the model will stabilise and help with how we develop that and reinforce the pathways and care that we've got in Prince Philip around acute medicine and the elective surgery work that we do there. So I think it's I'd agree with Mark's assessment on that in terms of how it helps us move forward with an immediate issue and challenge that we've been managing for a number of years. And I think it will be I think it's important for our staff and our teams as well to give them that certainty around what the approach is going to be.
Okay, thank you. Yes, please.
Diolch cadeirydd, a na I dweud hwn yn y Gymraeg. Mae hwn yn berthnasol I pob penderfyniad heddiw. Ar ôl I ni wneud y penderfyniadau, bydd na eisiau darlun I ni cael gweld beth sy'n cael ei wneud ble, gan pwy. Mae hwn yn gymleth, a mae'r cyfanswm y penderfyniadau mynd I newid lle fydd ni'n cael y gwasanaeth iechyd. A mae'n bwysig I ffindio mas I bobl cael gwybod beth sy'n mynd I cael ei wneud yn y gymuned, beth sy'n yn yr ysbyty, a beth sydd yn canolfan gofal integreiddiol. A mae rhaid I ni cofio ar ôl i'r heddiw, bydd rhaid I rywun mynd a wneud y darlun na. Os beth sy'n bwysig ar ôl heddiw, yw ni gallu gweud i'r cyhoedd, dyma beth bydd y gwasanaeth gofal yn edrych fel, y gwasanaeth iechyd yn edrych fel, a bydd hwn y gorau allwn ni wneud, a bydd rhaid hwnna dod nôl gyda'r cynllun busnes a'r arian a bopeth i'r bwrdd I wneud penderfyniad iawn ar ôl ni. Diolch cadeirydd.
Diolch. Thank you. Thank you, Eleanor. Yes, please.
Gai ymateb i'r sylw yna gan Eleanor, ysgolch yn dda cadeirydd. Dim ond eisiau atgyfnerthu y pwynt Eleanor mewn ffordd, a atgyfnerthu'r pwynt bod yn penderfyniadau ni heddiw ddim yn golygu bod hyn yn digwydd fori, a fi gyda ni ddarn eitha sylweddol o waith i'w wneud mwyn cyfathrebu yn union hynny mae Eleanor wedi grybwyll o ran darparu sicrwydd I unigolion, bod nhw pan maen nhw mewn poen neu mewn argyfwng, bod nhw'n gwybod yn union lle ddylsyn nhw fynd am y gofal cywir gan sicrhau bod pobl yn ei moment o argyfwng yn gwybod yn glir be di be. A fyddwn ni'n gwneud hynny fel tîm heddiw o ran cyfathrebu ein penderfyniadau, ond dros y blynyddoedd I ddod yn cyfathrebu yn glir wrth yn cyhoedd ble mae'n mynd ati I gael yr cymorth gorau posib.
Diolch.
Diolch.
Diolch. Yes, please. Yes, Maynard.
Thank you, Chair. It's a point of clarity. Option 246 is, if I remember rightly, actually option B with the added benefit of a hospital-wide management and on-call over that. So just clarifying on that, if we decide on going forward with 246, we will not need to go back to further consultation.
I'm happy to come in on that, Chair. So no, as that is aligned to the option that we consulted on, the way in which we're delivering that operationally is what is drawn out in option 246, so that wouldn't require further engagement with our communities.
Thank you. Colleagues, James, do you want to say anything?
Okay. Diolch, David. I think similar to the point Neil and the Vice Chair raised earlier, in addition to Lisa. So I think if I make the point now, so when we're talking about the opportunity that we've got with all these options, I feel the need to reinforce the point that the workforce perspective is going to be key. So many of these opportunities that we do see presented today allow the consolidation of the allied health professions and the health science workforce in many ways. There is significant opportunity in taking some of the decisions we will consider today in the short term, medium and longer term. So I just wanted to point out that to our public, our communities, that there is significant benefit to yield sooner than later with some of these options, which aren't always as evident as they appear to be at the moment. Diolch.
Thank you. Right, I'm going to come to Sharon, who I think has a comment.
I do, thank you, Chair. I just wanted to build on my comment about the quality impact assessments that I mentioned earlier. Just to note that the assessments also highlighted, as we've discussed yesterday and this morning, that the benefits of several options are contingent upon system-level enablers, particularly timely inter-hospital transfer, robust multi-site workforce models, and appropriate estates configuration, as we discussed yesterday. And that a combination of those enablers is essential to ensure the safe and effective functioning of more centralised and consolidated service models. So in relation to critical care, The Quality Impact Assessment panel noted that the option that strengthens or regionalises critical care, notably option 246, demonstrates clear quality benefits, including enhanced sustainability, improved adherence to the guidelines for provision of intensive care services, and more resilient staffing. So I just wanted to note that really, but it is dependent on the benefit. That benefit is heavily dependent on establishing that transfer service.
Okay, thank you. Which brings us back to that travel and transport and travel and transfer issue that we talked about earlier. Rodri.
Wel, I ddweud y gwir, Sharon, ti wedi ateb beth wethon ni'n mynd i ofyn, ond jyst yn gyffredinol wedyn, o ran yr opsiwn 246 a falle hefyd jyst yn gyffredinol adlewyrchiad bod ymgynghoriad yn gweithio mewn ffordd, a mae sylwadau sydd wedi dod allan o'r ymgynghoriad yn cael ei greu yn yr opsiwn 246 na, felly mae fe'n credu bod e'n gweithio yna.
Diolch. Chantal.
Diolch, Chair. I just wanted, it's an overarching comment in relation to all of what we're proposing with all the proposed changes, whether we have assessed what the cumulative system risk could be and its impact on patient experience.
Good point. I mean, I think largely what we heard yesterday was what would be the positive and negative impact of some of these changes if we were to make them. And largely they focused on patient experience in terms of the challenge of transporting people or the associations with that. I think the case for improving services or services being improved as a consequence of these changes was compelling. Our clinicians kind of presented a clear sense. But you are right, it's a complex system, and there will be other things that probably we haven't anticipated or looked at or been able at this stage to establish. And I think that calls for us to be vigilant in terms of when we make these changes as to what might be the unintended consequence or impact of the things we're doing inside this space. Good point. Lee.
Thank you. I'll just make 3 quick points. So 246, as Maynard has mentioned, is additive to the previous option B, and I think it is an important addition because what we're recognising within that is the fragilities and the vulnerabilities, particularly of the bronchitis intensive care service. So there was so part of the plan there is capitalising on the benefits of bronchitis being part of a wider hospital network, and therefore being able to seek additional support from Glangwili and other sites. So that is an important addition to the previous option. The other point to be aware of in terms of transfers, so we already have an acute critical care transfer service operating in Wales, so that happens already between sites, but clearly there'll be a need to think about how that may be enhanced. And then the final point, similar to what I've said earlier, so strategically we've already reached the view that we should have 2 intensive care units for to cover Mid and West Wales. That was our strategy in 2018, and I think what we heard yesterday reinforced the reasons for that. Yeah. We're not in a position to deliver that today or in the improvement phase, but I think it's important that we recognise that is still the long-term direction, similar to what we said with emergency general surgery.
Absolutely. So we have in principle agreed option A, because we agreed that in 2018 as our broad direction of travel. Yes, you're right, and that's a confirmation of it. What we don't want to do is step back from that. That's still very much part of what we would want to do in the future. Phil?
Yeah, a couple of points I wanted to make. That I suppose when you look at the public, the information from our public and our staff, around 50% of people preferred option C. Yet what we heard from our clinicians and our managers and from board members is just the real concern over option C, trying to run 4 intensive care units. We heard that standards had advanced considerably in critical care in terms of expectations, and yet because we have 4 units, that holds us back. in a lot of ways, in the kind of quality and experience that we can provide, the kind of sustainability, and adds to a significant recruitment challenge. So whilst we've have this information, we've listened very carefully to what the public and staff have said, I think we also have to listen to the real significant concerns we have of running even 3 units, let alone 4. This is what we heard yesterday. And these are the illest people in our communities at any one time on our critical care unit, requiring the highest levels of care, the most technical aspects of care that we provide. And when you're in that situation, the kind of expertise that you have and the sustainability of the services really does impact on outcomes that you have, and that and from outcomes we mean life or death, and also longer term disability or not. So this is a really significant service we're talking about here. So I agree with colleagues in the same way that we've discussed previously. Whatever decision we make, we have to, we will need a business case development, although hopefully we would be able to move to a health board-wide service as soon as possible. But I do think we need to consider that properly. I do think it's an enhancement. And I do think it would create more sustainability particularly for Bronglice actually being part of that network. On the longer term, option A, I agree that model was what we agreed back in 2018, albeit that in 2018 the one unit was going to be in Bronglice and the other one was going to be in a new hospital build. So I would anticipate we'll need to consider what engagement we would need to do if we were to move to that option. But for the population of Llanelli who are particularly concerned, this is about making sure that all of our population, including Llanelli, have access to the highest standards of critical care when you're really ill, the highest standards possible.
Thank you, Phil. Okay, can I suggest we agree a direction way forward on this and make a decision? Option 246. I'm looking at Mark because I'm.
That would be my decision. Yes.
Great. Okay, and everybody's nodding to that effect. So let's agree. Option 246, as developed within our communities, is the option we'll take forward in this case. But your point about option A and the long term and what we might need to do and come back for re-engagement or consultation is something we'll look at in the future and subject to the business case.
Yeah.
Great. Okay. Can I take us to our next service? Stroke. Okay.
Thank you, Mr. Chair. Just to do a quick recap on the options, what we heard yesterday. Currently, we have 4 stroke units across Hywel Dda. Those stroke units have a specialist stroke consultant and CNS Monday to Friday 9 to 5 outside of those routine hours. That's delivered by our medical emergency teams to support our patients. Stroke standards are changing, we heard yesterday. We should be working towards what we heard from the clinicians around an acute stroke units or 24-hour cares or 12-hour care unit models. So the options that are reflected on the screen are looking at ways in which we can meet the work towards meeting the standards and improve the agility around the medical workforce as well within the service across 4 sites. And those options are, in option A, it's 2 12-hour stroke units within the health board, and they're called out as being Prince Philip and Withybush. For patients in the other 2 sites, there would be a treatment and transfer option. To note, in the Bronglice, within all of the options, they retain the consultant at the site and the clinical nurse specialist at the site. So that is retained in all of the options at the Bronglice site. In option 210, which was an alternative option that came through the public consultation, we have an inverse of option B, which is almost working towards a 24-hour stroke unit at the Glangwili site with treat and transfer or at the 3 other units and developing Bronglice to be a 12-hour unit over time. And then we also heard a conversation discussion take place around a merged option 106 and 210, so elements of both. That's working towards a single acute stroke unit for Hywel Dda at the Glangwili site, treat and transfer at 3 sites, but with a specialist stroke acute rehabilitation unit at the Bronglai site. Just to note, rehabilitation, please note, it is different for stroke. They have specific standards around stroke, and that includes up to 3 hours of rehabilitation a day required post-acute care. So that's why rehabilitation is specifically called out within stroke.
Thank you. Thank you, Ben. Very helpful. Mark.
Diolch, Cadeirydd. I think what I first want to do is recognise the significant interest and involvement we've had in stroke care within our health board. The reason for that is stroke can be a devastating condition and result in long-term, lifelong disability. What that means is not only do we have a duty, but we have the ability to offer the highest level of care. And that's what we're not doing at the moment with our current system of trying to provide care at 4 sites. So change is absolutely necessary if we're to produce the best outcomes for our patients. I think the other important thing to describe is the treat and transfer model, and I think there has been some confusion about that. What we are proposing is that all patients will receive immediate emergency treatment at their local hospital. And what that means, they'll have the scan and they'll have the clot-busting drug, if they need it, given immediately. And there's been a lot of confusion about using terms such as the golden hour, for example. The golden hour doesn't refer to stroke, it's about trauma care. But what we refer to in stroke is giving patients treatment as quickly as possible. And in all of the options, we will ensure that because we will treat patients immediately and then transfer them to an appropriate specialist unit. Now, what happens in that appropriate specialist unit is then you have direct access to specialists who will ensure that your recovery happens in the best possible way. The option A that we developed goes part way to doing that because we indicate that we have a 12-hour service on 2 of our sites. Option 210, which came out of the public consultation, is more in line with our long-term strategy, which is about having 1 site that would deliver 24-hour care. And obviously 24-hour care will deliver a high level of care than simply for 12 hours. And Glangwili is our major acute hospital in the health board, and that's in line with our direction of travel. Option 106, which if you remember, did describe having a stroke unit in Bronglai. So there obviously are significant advantages to that, and that addresses some of the concerns that quite rightly patients in Mid Wales have had about support from families during that recovery phase. So potentially merging the 2 options, 106 and 210, does give us that option of supporting patients to be rehabilitated close to home, and also is in line with our long-term strategy of having 1 acute site for stroke care. But again, to reiterate that patients will receive that immediate treatment at their local site, meaning that their outcomes will be ensured.
Helpful. Just describe to me that process. So technically, if someone were treated and then transferred to a specialist centre, how long would they spend at that centre?
So that will depend, but it will on average be about 72 hours. And that's what we're talking about, the hyper-acute care, when we'll have specialist consultants, specialist nurses, physiotherapy, other allied health professionals to support that patient, to ensure that they don't develop complications. If complications arise, then they'll be picked up early and managed. Some patients, as you know, already do travel for stroke care. There's thrombectomy, which is the surgical management of a stroke. Currently, patients will either go to Cardiff or to Bristol for that care. And that affects all patients in Wales. All patients in Wales go to Bristol for stroke care. So whilst transfer and travel is something patients are rightly concerned about, this is something that happens now. But in this model, what we're doing is still trying to ensure that patients have care delivered locally and will be returned home as quickly as possible. And with better quality care in the early phases, we will ensure what patients have early supported discharge. So we'll maximise the number of patients who can go home within that first early phase.
Very helpful, thank you. For a point of clarity, Nikki, I'm presuming if we were to think about the merged option of 106 and 2110, that we would need to re-engage communities.
Yes, and that is also the case for option 210 by itself, as that is fundamentally different locations from those that were consulted on in the options for stroke. We would need to understand what the impacts would be for those communities, because we wouldn't have been able to capture that during the consultation, because the options presented didn't allow those communities to share those perspectives with us.
Thank you for the clarification. I know Roger wants to come in. Andrew, anything you would want to say?
I suppose, again, I'm in danger of agreeing with Mark again, which might not be a bad thing as my medical
Occasionally,
director.
anyway.
But I think the key things for me are operationally it would, and from a deliverability perspective, a single specialist stroke unit for the health board is probably the only way we're really going to be able to deliver the standards of care that we require. The level of resource and staffing that we would need to deliver that on multiple sites would be unobtainable for us, I believe. So I think that has to be the direction of travel for us going forwards. I'm also, though, a bit like Mark, having attended a number of the engagement events, I was really taken by the feedback we had from the public around the importance of relatives and carers in the rehabilitation and care of patients post-stroke. So I think that is something we need to really consider as part of our decision.
A really important point. Thank you for that. Before I bring Bwrdd in, James, is there anything you want to say?
Diolch, David. I think what I'd add is maybe reiterating the point that we heard yesterday, or I described yesterday. So this acute phase, the most sensitive part of the stroke care that our population who suffer stroke need support with, is absolutely the first 72 hours. And I do wonder how transparent and how accessible we've made some of the terminology, for example, treat and transfer, and how accessible it's been for some of our communities to understand out of the 7 parts of the stroke pathway, the most significant part where they absolutely need that immediate support is the first 72 hours, and how much we've been able to articulate and explain the significant amount of rehabilitation needed by a number of different professions within that first 72 hours, and then what can be delivered locally, closer to home, surrounded by the loved ones, people that they depend on to support with their care and rehabilitation needs. And I do wonder if I don't wonder actually, I think from my perspective as an allied health professional and representing the UHB and health science community, some of the things I think we need to strengthen is that understanding of what can be done within that acute phase and what absolutely can be done closer to home with the loved ones and the support of those people that are important to people who've survived stroke. And I think that feels really important as part of our deliberations and outcome today, not just a medical perspective.
Yeah, very helpful, because I think I mentioned yesterday that I think sometimes there's a disconnect between process and delivery and patient experience. So I think the way patients experience it is different from the way in which it's often articulated from a clinical perspective. That's not saying either are wrong, but I think sometimes a gap develops between those two. What I expect as a patient, or what I want to experience as a patient, isn't often described to me. And better description, better articulation of that would give me reassurance that actually there was something better going to come out of this process. And I'm not criticising anybody for that. That's the nature of how we develop our services and grow them. Thank you for that. Rodri and then Neil. Sarah.
Iawn, fe ddechrau yn y Gymraeg, jyst ddim eisiau ailadrodd, a fe ddim yn ailadrodd yn byd nes I weid ddo. Firstly, I just want to reflect perhaps on, Nikki, what you said yesterday, yesterday afternoon, just regarding the planned care and also the acute care. You made it quite clear with planned care, people are willing to travel because they know there's a centre of excellence somewhere and they can see that. When it comes to acute care, they wanted things closer to home, which makes sense, and I agree with that totally. And I've been reflecting as well, and Chair, you quite rightly say that we always work on the design principles, don't we? And with equity for the population essential in any decision made. And with the options in front of us for stroke, to have equity for patients and families travelling to see family 4 hours down to perhaps Prince Philip, Withybush, travel is a big issue, and there needs to be, in my opinion, a north and a south provision for stroke, and bronchitis would be essential for the north part. Towing and surrounding areas, as I said, yeah, it's just a long way. The roads are terrible, and it's a 4-hour journey. It's not so much perhaps, right, okay, when it comes to a person having stroke, if they have to go somewhere else, but then that after that 72 hours, what happens? Family might have to go for, because the rehabilitation takes a long time, takes months sometimes, and to lose a provision so close to, well, kind of someone having to travel kind of to see their loved ones and help them, because we're always kind of, when it comes to people in hospitals, the nurses work very well and very hard working, but also the families need to also be there as well. They need to help kind of, and they also kind of, I think, improve the chances that people get better sooner. But I do think that kind of looking at the options that are here, I could not support option A. The option that I would look at kind of would be the 210, but it would need to be the stroke unit and also the rehabilitation part of it as well. In that, I know there's a hybrid, there's a merged option there. But I do think, kind of, Cathy, you said earlier on, and I wrote it down, transport is an issue, we all know that. And you said quite clearly that we need to mitigate any impact that we do. And transport, I know it's not just in our gift, it's in everybody's gift, but that impact kind of, there isn't a mitigation in a way. So people would have to travel down 4 hours down the road, for months perhaps, and I can't see that. I don't think that's acceptable for any decision that should be made. So with those few words, as I said,
They weren't that few.
Well, I think they're important words, Chair.
Of course.
I think they're very important words, and I think it's important that I do get that across. And as I said, I think the treat and transfer, we agree. And as you say, Mark, people kind of, those from Aberystwyth, a lot go and get treated and transferred and then come back at the moment. There's some serious cases where they have to go to different locations, but they do come back and they do get that stroke care in Aberystwyth and the rehabilitation. And I think kind of none of those options really match kind of what I feel should be our kind of priority. It should be the stroke unit with the rehabilitation. Okay.
Okay. I'm going to come to Neil, but Mark, just a thought on the practicality of that.
I think the issue is about what we don't have currently is a sustainable service, and we don't have the level of service that we would wish to provide. And you heard yesterday from our stroke lead about the standards that we are not currently achieving. And I think as Sentil described, I'll use the technical term, we're at level D. And I think we all know that is not good. We cannot provide currently, and I don't think we will be able to recruit medical staff to be able to provide that unit in bronchitis. Unfortunately, I think we absolutely hear what has been said to us. I think that the numbers of patients involved mean that we should consider what transport and travel support that we can give to the relatively small number of individuals this would impact upon. Could we consider support in terms of hotel support or other forms of accommodation support that we could consider? That's what's been going through my mind. What's really important is that we get that acute care and we get that 24/7, because as I described, the outcomes from stroke can be death or they can be long-term disability. It is really important that we get it right, and we get it right for every patient. I don't think that we're going to be able to do that in 2 units. I think what we have to also, we did talk about the All Wales direction. Historically, what that has meant is no stroke unit in Hywel Dda at all.
Is that the All Wales?
That has historically been the direction, that we don't have the population large enough to have our own hyperacute stroke unit. Now, we don't know which direction that the national direction will be, but I think it probably would at least say that we would, or most say that we would have one stroke unit in Hywel Dda.
Yeah, okay. Thank you, Mark. Thank you, Rodri, for your honesty and your openness about that. Neil.
Thank you. I found this really powerful yesterday, listening to the story and the evidence from the Stroke Association. And I'm sure I'm not the only person in this room, but it brought back some memories of someone whose family was impacted by stroke 25 years ago, not in this region, but it was really, it kind of led to a lot of reflection, actually. And it's a difficult one, isn't it? Because I think there's a few things going on here. There's the myth busting around the treat and transfer, which I think we absolutely need to spend some time on. It brought me to the point of thinking about preventions. So we know that hypertension can be one of the major causes of stroke, and there's things that people can do to prevent and help. But the thing for me that really struck out was about getting the best possible outcome. So it kind of led me to the point I made earlier around some communities might feel a sense of loss, but that in no way compares to the sense of loss from losing a loved one.
Indeed.
And so I think we have a good opportunity here to take a difficult decision, but what seemed to be the right and the safe decision around the merged option of 106 and 210, but the opportunity to go back out and go beyond consulting, but actually have a proper conversation with communities around stroke, around prevention, around treat and transfer, and around that it isn't just an event that happens, but it has a long tail. So I found this really powerful yesterday. And even though it's a difficult decision, it feels to me like the merged option would be the right way for us to go as a board. Thank you.
Very helpful, thank you. I think you've said lots that we would all agree with in that. I'm going to come to Sarah. Andrew, anything you would want to say?
I can wait till after. Sorry, I can wait till after Sarah. If you want.
And I know that Alwena wants to come in as well.
Chair. So
and Lee, okay?
I guess it's just a point of clarification. So when we're looking at the merged option, I just want to be really clear. So that has not gone through hurdle criteria. It has not gone through the evaluation scoring. So I just want us to be cognizant that that might be our preferred option, but we don't have the reassurance.
No, it would have gone
around
through hurdle criteria, hasn't it?
No, I don't think it. I don't think it has. That's what we were told yesterday. It hadn't.
Yeah, so I can come on this one. So that isn't. We haven't called it an option. We called it an idea, specifically because it hasn't gone through as a individual option. So we've tested the elements of 106, and we tested the elements of 210. What we haven't done is tested both of those bits together to see if it compares still favourably against the criteria.
And presumably it wouldn't have met the hurdle criteria because it's outside the scope of what we originally, outside the scope of the original consultation.
It's within the scope of the consultation in terms of the consultation looked at addressing our challenges within stroke, which is why it was the elements of that option were assessed. But because the idea came together after the scoring exercise when reviewing the options we had against the issues that we were seeking to address, it passed the point where we hurdled and scored the options.
Fine.
So if this was something that you would want us to do, Nicky's already mentioned about the engagement.
Fine.
But we would also have to do that additional work then to actually do the same level of indicative workforce and finance assessments and score it so that we can compare it to the other options we're
Okay, thank you, Alex. I stand corrected. Okay.
Yeah, I think it's just an important point to note that we're not necessarily comparing apples and apples in terms of our assurance around that blended option. I'm not saying it's not a good idea, but it's not got the same had the same scrutiny process as the other options.
As we would have worked through the rest.
Thank
you. Lee, I know you want to come in. Alwena, you've been patiently waiting for a while.
Dim problem, diolch yn fawr iawn. Mae'r rhan heleth o hyn o'n i'n mynd i ddeud wedi cael ei grybwyll gan Alex a Sarah o ran y gwaith ymgysylltu fydda angen i ni wneud ar yr opsiwn gyfunol. Ond jyst eisiau atgoffa unigolion o'r pwynt nes i ddoi ynglyn â'r iaith Gymraeg, a'r adborth gafon ni gan deuluoedd ynglyn â'r trafod concern ynglyn â trafnidiaeth, bod hefyd concern ynglyn â'n gallu yn staff ni ddarparu gwasanaeth drwy gyfrwng y Gymraeg ar gyfer unigolion sydd falle'n colli'r sgil o ran yn ieithyddol fel sgil effaith o gael stroc. Hynny yw bod pobl mond yn gallu siarad Cymraeg ar ôl cael stroc a bod angen y gefnogaeth yna o ran deall y cyfathrebu fel claf a fel teulu. Bydd hwnnw'n rhywbeth fyddwn ni'n edrych arno fel rhan o'r gwaith asesiad effaith. Fydd yn mynd law yn llaw gydag unrhyw un o'r opsiynau fydd yn cael ei benderfynu. Felly eisiau rhoi rhywfaint o ystyriaeth i hynny a cefnogi yr adborth gan ein cymunedau.
Diolch. Diolch. Lee.
Great. Thank you, Chair. So stroke is clearly a very important issue for us in our deliberations today. I think I go back to the why, I guess, in when I'm thinking about this. So most of us are residents of the area, and many of us will have been affected by stroke. As Mark said earlier, it is a devastating condition that doesn't affect people for days and weeks, but for years afterwards, and destroys lives for individuals and their families. So the critical question for us is what gives those individuals the best chance of full recovery and avoiding disability. The evidence is very clear, which is why the Stroke Association, the UK guidelines on stroke, the Welsh All Wales quality statements, all advocate for fewer units with more intensive support to provide better outcomes. What we've seen with stroke is it's gone from being a general service that is available in every local general hospital to a very specialist service. And specialist services are typically delivered in few centres. And for our population, that means if it's major trauma, we already access that service in Cardiff. If it's thrombectomy, we go to Bristol or Cardiff, as Mark mentioned. If it's neurosurgery, we go to Cardiff. If it's cardiac care, we often go to Morriston. So we are already accepting the principle that we have to travel further for that specialist care. Option A is the most deliverable option, which is why the Options Development Group proposed that one. As we sit here today, that is the one that would give us the most immediate benefits. As we described, though, there are challenges with that, as we've heard through the consultation and strategically. 210 does give us some additional opportunities. I think there is a very significant challenge for us around the idea of a stroke unit providing specialist cover 12 hours a day in Bronglais. The critical mass isn't there, so I think we need to be honest with the public that that would be a very precarious service, which means if you have a stroke in that area, you run the risk of not getting the highest quality care. So if we were to go down that route, that would be a compromise, which personally I wouldn't support on behalf of residents of that area. What I do recognise, though, and which came through very strongly through the consultation, is we do cover a very large geographical area, and what we haven't mentioned to date is stroke services we provide on behalf of a wider population than just Hywel Dda. So Powys, South Gwynedd are constituents of our stroke service. So we need to think when we're designing our options how best to meet their needs as well as the Hywel Dda population. I think for stroke, the key question comes down to how many sites we can sustain for stroke services. We start with 4. We've got options that effectively become 3, 2, 1, and even, as Mark says, 0. If we were to follow the direction of travel that has been advocated nationally, we would not have a stroke service in Hywel Dda. So as I go back to what I said right at the start of this, which is we do have an opportunity today to set a course that, one, provides our patients with the best quality of care and the highest standards, but secondly, secures the long-term future. Now, I personally believe that we can sustain a stroke service in Hywel Dda, and we can provide good quality of care. If thrombectomy became available in Morriston, that might be a slightly different question. But as it stands today, I think we can, but I think we can only do that in 1 unit. That would be my view. Recognising that, though, I support the idea that patients on their rehabilitation should be as close to home as possible, which is why I would support a rehabilitation unit in Bronglais, recognising the proximity to families and friends for members of that community, South Gwynedd and Powys. Thank you.
Thank you. And I'm presuming that's aligned with what you would think as well.
Yeah, I think Lee has very eloquently described all the points that we brought up, so I would support that as well.
Andrew?
Yes, thank you, Jay. And I suppose I just want to add to what Lee said, because that's kind of where my thinking was starting to go. So when I look at this and I reflect on the conversation we've had yesterday and this morning and the feedback we've heard through the engagement process so far, I sort of break the stroke pathway down into 3 parts. There is the first 4 hours, when the key part of that pathway is about getting somebody from onset of stroke symptoms to a CT scan for assessment and decision on whether they need blood clot busting drugs or thrombolysis. The treat and transfer model would make sure that we could deliver that, which is really important. The next phase then is the next 72 hours, where we need a really specialist level of care and input to maximise outcomes, and we could not, I don't believe, deliver that on more than one site 24/7. So again, I would support Lee's view that a single site for that acute, hyperacute element of the pathway in Hywel Dda is the right way forward. I was also really persuaded as well through the engagement process around the importance of families and carers in that rehabilitation path of the pathway. So how we could provide that, particularly with our geography and the between, I guess, the north and south of Hywel Dda, I think how we could provide and explore the provision of a rehabilitation unit in that model, I think is a really important element for us to think about. So I would concur with Lee and Mark that I think doing some work to explore whether that merged option that's come out of the feedback we've had is something that we could take forward sustainably would be probably where my thinking would be this morning on the back of everything we've heard.
Thank you, Andrew. I'm going to come to Eleanor and then to Phil, and then I'm going to move us to a point where we make a decision.
Diolch, Cadeirydd. Mae hwn wedi bod yn her rhwng calon a pen. Yn hollol onest o hwnna. This is a real challenge between head and heart. I'm from the area, I'm back in the area, I love it. Nobody wants to see a service moved. But we're not losing a service, is where my head has come to. We are trying to provide the best care to a life or death situation or a long-term consequence for an individual who suffered a stroke. That's really hard, because I want to say the family want to surround that person, the person wants to be surrounded by their family, and we don't want to see things moved. And not just overnight, but for a long time I've been arguing this with myself. I think I can only honestly come down with the clinicians and guidance nationally that to have the best service possible, it has to be one specialist site with, yes, rehabilitation nearer where people live. I think it's a really hard call for all of us. My guiding principle is what is going to help that individual have either life or the best quality life after the incident. So hard as this may seem, my head says I would vote for the merged option 106-210, and we need to work that one through.
Thank you, Eleanor. Very helpful. Phil, and then I'm Maynard, and then I'm closing it for comments and just going to.
Sorry, Chair. I think Eleanor expressed most of what I wanted to say very, very eloquently. Then, the only other question remaining in my mind is, with the current fragility of the service, is there anything that we need to do now? Because that merge option is going to have to go through an awful lot of, first of all, passing the hurdle, which I'm assuming is going to, otherwise I don't think they would have tabled the idea. But then it has to go back out to consultation with the public, all of which is going to take a matter of months. The analysis, you're probably looking at best part of a year before we even know whether that is a viable option after consultation. We have a fragile service now. Do we need to implement any of the other options now as a stepping stone to where we're going?
An interesting question. My first thought was that's not for consideration. unless, of course, it's delivered through one of the other options inside that space. Mark, would you want
So
to
I think the answer is no, in that we have safe services currently. We are not in the position that we need to institute an urgent service change. Sometimes these things become necessary, but I don't want to overly concern people. We have a safe service and we have mitigations in place. What we're talking about is what we can do to long term, and I appreciate that further going back out to the public and further engagement will take time, but I think as we've all heard, we think this is really important because this is really our chance to get things right.
I mean, in truth, so the service is being provided, but it is not the standard. It is not the standard we want to deliver or people deserve in West Wales for stroke services. So that's the key issue. Yes.
Diolch, Cadeirydd. And look, we've heard that this is a really significant service. It's a real dilemma for us as a board. Incredible public interest, and all of us I know have learned a lot from engaging with the public and our staff through this process. And in fact, given the new options, I think that demonstrates how we are being influenced by the public. I think when we say that we are not meeting the standards, which we aren't, that isn't a reflection on the hard-working staff that we have working in all those units. The dedication and commitment that they provide in all of our units is really significant and quite challenging, given the fact that they aren't working in a unit with all of the peer support and sustainability that you might see in other units. So the service they provide to our public, given that situation, is quite remarkable. But all the same, stroke standards and expectations around stroke care have increased significantly in the last 5 to 10 years. It's no longer considered a general service that you expect everywhere. It's considered a specialist service. It isn't sort of integral to whether a hospital can function as an acute unit or not. It's a specialist service that has to be considered separately. I suppose we've had significant additional information from the public. That's where I say this is a dilemma for us.
Recording
and I think
in progress.
what we're hearing from the public, what we're hearing from our experts is a real concern over whether we could realistically deliver a sustainable service 12 hours a day in Bwrdd. I do think, though, the point about the stroke rehabilitation unit becomes really important, because for people living in Mid Wales, the possibility that we could it becomes really important not only to have your initial treatment locally, the thrombolysis clot busting treatment, but also if you were to move to another unit, that you come back quickly. And I think there's all sorts of opportunity with us being creative and innovative about the kind of rehabilitation that's provided locally, and there might be exciting roles for staff, I think, if we're really creative in that regard. So I think on Maynard's point, I think that would be a different question, as if we had to make an urgent service change. I think these changes need really careful consideration before implementing, really careful business planning, and in fact, further engagement with the public, given the fact they are new options, which in fact, we indeed not only need to engage, we need to do further work internally around our gateway processes. So we do need to look through in more detail.
Okay, so I'm going to...
Sorry, Chair, there is a problem on Zoom, so they can't do anything. The Wi-Fi's dropped. Still recording. Just to flag that we might just need to recap the break.
Okay, so I'm going to go back to Well, Neil, you raised it first in terms of supporting what would be that merged option 106 and 210 here. And it seems to me the conversation around the table, it seems to me the conversation around the table has largely been in support of that merged option, which I think came forward from the community. As we've heard, that will necessitate a further period of engagement if we decide that that's how we would want to move forward. But it does seem to me to move closer towards recognising the challenges and potential detriment of travel associated with loved ones and carers supporting people who've had strokes if we were to explore the notion of that stroke rehabilitation unit at Bronglais. So I think that's kind of, notwithstanding that, I would still reinforce that view that we need a broader kind of transport and kind of travel service between our sites and do that strategically. So we do need to support this with an underpinning of how our approach is to ensuring people can travel to the appropriate sites, whether they're transferring or not. The sound is back. Thank you. Thank you, Phil. Great. Okay, so can I ask if people are supportive of that merged option of 106/210? Eleanor, you not just want to say something?
I'm indicating I'm supportive.
You're indicating supportive of it?
I'm not supportive of that. That's my problem.
Okay, we accept that, Audrey.
Right, could I just clarify how long this second consultation would be?
We would have to explore that, and the team would need to go back and look to see. It's not a consultation, it's an engagement.
Engagement. Okay, thank you.
But Nikki, is there anything you would want to add?
I didn't know if Hywel wanted to comment on that. It was just to say that this would fall under the statutory guidance. As part of the consultation, there is an opportunity for a second phase if there's further information that is needed that comes out of the consultation, so what we heard from our communities. So this would fall under that category, and the guidance states that it needs to be a minimum of a 6-week engagement period, but we will just need to be mindful of obviously the work that would need to happen before that in terms of formal assessments against hurdle and evaluation criteria, as well as the documentation that would need to be developed in order to support conversations with our communities. And obviously we have a pre-election period upcoming shortly too, so we need to be minded of that in our timelines.
Thank you.
Thank you. Jo?
Yes, Chair. So just on behalf of our Executive Director of Nursing, just to flag, we'll also need to do revised quality impact assessments as part of this process as well. So Sharon just asked for that to be recorded in the minutes, Chair.
Okay, so I'm conscious we did lose sound for a short period, so just to... It was just when Phil was talking. Fine, okay. Fine. So I think we've broadly got the summation of our decision in relation to why we're making that decision and what we would like to happen as the next steps in terms of taking this forward. Thank you very much. Let's take a refreshment break and then reconvene. Just 10 minutes, I'm being told. Yeah. colleagues, for coming back promptly. Can we now move to our next service consideration? Ben.
So this slide...
Not Ben. Sarah.
Apologies. So this slide highlights the key considerations that you heard yesterday from the public consultation feedback and the services...
Sarah, pull the microphone to you.
Apologies. So this slide highlights the key considerations that you heard yesterday from the public consultation feedback and the service appendices for ophthalmology, orthopaedics, dermatology and urology. So some of the key considerations are again travel and transport, regional working and the value of extended hours.
Okay, thank you very much. Can we go to our first slide? Great, so ophthalmology. Mark, I'm going to come to you again.
Thank you, Niels. So I think that the important thing for me clinically to say here is that both options are clinically acceptable and would deliver a good quality of service to our health board and our patients in the health board. I think there are issues, I think, described in the difference between the options about, again, still the numbers of sites that we are proposing to continue to provide ophthalmology services from. And that has historically been an issue for us. As you heard from Vicky yesterday, the issues about staff travel. And also it isn't really attractive for staff to travel to lots of services. So therefore, the less sites that we provide services on, I think that the better we're able to provide the care that we need. We also heard the description of between the two options of the service in Brongice. Currently, we're providing a low number of cataract operations in Brongice, and the issue whether that is sustainable going forward. I think what is important to call out is that the North Road Eye Clinic in both options will continue to function, and it's a very important part of our ophthalmology service to Aberystwyth and to Mid Wales. So I think, as I said, clinically both options are viable, but I think have some operational pros and cons, which I think maybe Andrew would want to comment on.
Thank you, Mark. Andrew, any thoughts?
Yeah, I mean, I think we heard yesterday that certainly the national guidelines from our clinical network in Wales, and also from the Getting It Right First Time team that have reviewed services across Wales, is that we should be looking to move to fewer high volume elective surgery centres for eye care. We also heard yesterday that quite often for us to be able to maximise the slots on a list, doing some of those, running cataract lists, for example, in a main theatres environment such as we have in Brongice, isn't necessarily the most efficient or effective way to do that. But in somewhere like Amman Valley, which is set up and geared up for that, we're able to deliver as many as 8 cases per list, which would be what the expectation would be going forward. So, I mean, I think that would be something I would want us to be mindful of as we go through this. I think then there are probably, as we heard yesterday, there are probably other benefits or opportunities that then affords us in terms of operational service delivery. But first and foremost, it would be for me around how we can move in alignment with what the set national expert opinion and guidelines are on that service model, bearing in mind that most, as we heard yesterday, the vast majority, well, all eye cases are, there's very few overnight cases that we look after, so they tend to be day cases as well, so another reason why you wouldn't want to be doing that work in a main theatre environment.
Great, okay, thank you, very helpful. Alex?
So I didn't do a summary for this option before the discussions began, but I just wanted to point out, so in the discussions yesterday, and as Andrew just mentioned, Amman Valley doing both those services. So in the option 173 is shown there, it shows that service in Amman Valley. But also just to say, just to remind members that in the conversation yesterday, the service talked about Abereiron Integrated Care Centre doing the diagnostic hub, and whether or not that's something you want to consider for option 99, if that was a preference of way to go. So that's not on the screen, but that was part of the discussion yesterday. I thought might be useful.
Thank you, very helpful, because there was a divide between some of those things.
I mean, just to respond on that, I think, and just to give, I think there is a revised national view around the implementation of diagnostic hubs, which would mean that we would be looking at that as a service development, as an organisation in response to national policy direction. Anyway, that's emerged particularly in the last few months. So since we've been running through this process, so I think that's something we would need. Yeah, well, it could be anywhere, but Abermeiron would be a good location for that. Would be what I'm saying. So we could. It might not be explicitly written in option 99, but as part of our response to what will come through from the national, from Welsh Government and from the national policy position, it would be something we would need to explore anyway.
Great,
if that helps.
Thank you. It's very helpful. Hugh, and then Iwan.
Diolch, Cadeirydd, i fod yn glir, bydd angen achos busnes ar gyfer unrhyw datblygiad fel yna yn amlwg.
Diolch. Iwan.
Diolch, Cadeirydd. Just referring back to yesterday in terms of the collective of the planned care services that we're looking at, we've heard a lot about in terms of travel and transport and in terms of the patient experience. I think whatever decisions we take in terms of the planned care services, I think we really have to just kind of be mindful in terms of, as an organisation, our duty of care to those patients in terms of how we support them when they come into our care in terms of the planned care services. Simple things we heard from Ophthalmology yesterday about those patients and members of the public coming in who don't want to kind of come in later because they don't like then leaving the building and driving at night and the kind of impacts they have. So surely we should also be mindful of the decisions we're taking in terms of planned care, but also to kind of just remember the ripple effect in terms of, for those kind of patients, well, can we not do our older members of the public first at the start of the day? Yeah. And in terms of the extended hours, which I know we're looking at in terms of planned care, to do those people who are working during the day, so they come in the evenings or weekends, so they don't have to take that time off. So I think within the planned care suite of services, fewer sites, yes, absolutely, where we can have the specialist care, but also being mindful in terms of the community role, in terms of some of the prevention opportunities that we have in terms of planned care, where we're talking about sites such as Cardigan, Fishguard, and hopefully when Cross Hands comes on stream, but also in terms of the preventative side, working with our community and third sector organisations around the preventative measures, working with public health and the wider services to make sure that we're all joined up. And also in terms of the transport, we talk about making sure that there is sufficient public transport, but we also need to be mindful in terms of the decisions we make to then engage with the likes of Pembrokeshire Associated Community Transport, Dolen Tyfi, who can work alongside us as part of a long-term solution and a sustainable option for people, particularly around the planned care services.
Thank you very much. You make a number of important points, and I think you're demonstrating how important that strategy is, a strategic approach to building that, to building more resilience in the transportation systems that exist, which can help patients and carers kind of get to the right place on time. I completely agree with that. I also think you make a really important point, Ewan, with regard to the mindfulness of how we plan appointments for individuals. I sometimes think we do not make it easy for patients inside this space, and we certainly wouldn't be intuitive enough to work out the things you've just said, and yet that's not difficult for us to do. That's not difficult for us to do. So we need to be much more mindful, generally as an approach, when we think about people accessing these services, especially if we're relocating those services, as to how we can make it easier for individuals to attend, not just the transportation issue, but just to arrive in good time for them, not for us. Not for us. Yeah, great. Okay, were you going to say something?
Only to say that specific issue is a very live issue for us now, and we had a discussion at the Quality and Safety Committee last week on waiting times and waiting times management, and that issue was one of the things that we were clear we needed to be doing better on and working on anyway.
Good.
That's very good.
That's very good. Great. Rodri.
Diolch yn fawr, Cadeirydd. Ni'n edrych, fi'n deall na ni'n edrych yn uniongyrchol ar ophthalmology nawr, ond just o ran hwnna, achos gath ei ddweud ddo, fi'n credu gyda Alex ar rwy'n, os bydden ni'n mynd am yr opsiwn cyntaf yn 99, wel, os bydden ni'n mynd am y opsiwn 173, bydde'r opsiwn yn yr un nesa ddim yn gallu digwydd. Am I right to think that? I just want to be clear, I'm clear we're looking at ophthalmology, but then making a decision on that, and if we're looking at the next one, the orthopaedics, kind of the inpatient, increasing the orthopaedics could not be done. They are related. Am I right to think that? Kind of, that's what I understood yesterday. So I think we need to be clear on that as well, myself.
You're right. We did. They were slightly intertwined yesterday.
Because there'd be an increase in outpatients if if the ophthalmology did cease in option 99. So I think if we made that decision and then came back, we wouldn't have two options in the next one, from my understanding. I don't know if someone can...
I know, but we need to... No, I completely agree with that, but we need to understand these options on the merit of the case here, and then deal with the consequence of what that might be for orthopaedics afterwards, but they are intertwined.
Yeah, perhaps if I just clarify that point, because you're right, that did come up in the discussion yesterday, Rodri, and it's certainly how we've described it through the sessions that we've had. So I guess just for clarification, what was described in relation to the ophthalmology and orthopaedics is there are a certain number of sessions that are staffed, resourced to deliver the theatre sessions in Bronglais. There is a trade-off within that between services, and obviously orthopaedics and ophthalmology are part of that trade-off, that other services are considered within that. What I think it is important board members are aware of, though, is that we do have other vacant theatre sessions in Bronglais. What we don't have is the staffing for that, or necessarily the resource to support that. So I'd probably agree with Chair. I wouldn't want us to get too distracted around one or the other, because depending on what board think the right configurations are, we then need to take that into the implementation planning.
Thanks for clarity.
Thank you, Lee. Very helpful. Colleagues, questions or views? Neil.
Thank you. Yes. The bit that confused me yesterday with this was we heard around the case for change, workforce fragility, patient experience, and potentially too many sites. But we've got two options. One, I think, goes from 5 sites, and the other one goes to 9 sites. So surely option 90, well, I guess I'm looking for that confirmation that option 99 is the most sustainable in the long term.
Are you stating the obvious, or asking us to agree with that?
I don't know, actually. I mean, the other part of it is this really starts to bring in some of those community-led services as well, doesn't it? So,
of course,
yeah.
Of course. And to be honest, notwithstanding the fact we will need to provide clinical hospital care in relation to cataracts, the more engagement we can create and sustain inside communities for the non-cataract based interventions, the better. So all of those cluster under the community seems to me to be deeply important, including North Road in Aberystwyth, when we think about how these things will unfold in the future. Good point, I think. Andrew, did you want to come in on that, or anything we might want to pick up in what Neil said?
No. I think he's. I think you've articulated the situation well. I suppose the difference for me would be, I think, potentially the option that was starting to be suggested yesterday through the conversation, and which Alex flagged at the beginning of this item, was that the preferred option would probably, from a service perspective, be option 99, but with the Abereiron element added into it. So actually look at diagnostic hubs anyway. So it'd be something we'd have to explore in terms of how we did that.
Thank you. Michael.
Thanks, Chair. Well, my clarification was on exactly that very point, because in my notes yesterday, I called it 99 plus. Okay, and I think I totally get what Andrew says, that it might come to pass, as it were. But I think, for certainty, I would prefer the 99 plus, the decision to be on 99 plus, because I'm very enthused by the community model, which this embraces to the full ambition. So I would ask us, when you ask us to vote, Chair, I would ask 99 plus be the option.
Okay. Thank you, Michael. Colleagues, any other views? Yes.
So just reflecting back on what we heard yesterday, and it picks up on Michael's point. So ophthalmology is, we've talked about services up to this point which are very much about acute hospitals, whereas when we come to talk about ophthalmology, the majority of the activity is being delivered in the community settings. So whilst we've got 4 boxes that talk about the acute hospitals, then 1 box the community, the balance is actually the opposite to that. And I think it's really important that we bear that in mind. And if you recall the conversation that we had yesterday, we were given a clear steer that the service were trying to arrange the service such that for frequent attendances for injections and other things, which obviously we have a number of patients that require to attend regularly, they would be delivered as close to home as possible in those community settings. And then for the relatively rare events of needing a surgical operation, that's where we would centralise in order to deliver the productivity and efficiency benefits that's been described. So I think it's just really important to get that message across. The other point that was mentioned was we are having to outsource a number of, quite a lot of activity relating to ophthalmology because we can't deliver the activity ourselves. So the current model, although we've described it in relation to our sites, there's actually an additional provision beyond our sites which patients are having to travel to. So clearly, in any solution that we develop, what we're keen to do is deliver through that productivity and efficiency gain an ability to repatriate that activity into Hywel Dda. So that is equally important. From the point of view of which option, my personal view would also be 99 plus the incorporation of Bwrdd Integrated Care Centre.
Great, okay. Hugh.
Forgive me, Chair. Don't worry, I'm not going to. I think it's really important in talking about the plus that we do need to come back to a future business case that will be predicated on repatriating activity or on delivering that activity in a different way. So I don't want to create a commitment here that we need to follow through on that commitment to make sure that there's a business case that comes back in due course.
Of course. So I think back to where we began this morning, I think at this stage we are endorsing this as the direction of travel, notwithstanding all the necessary steps we will need to undertake to progress it beyond this point. Can I ask whether board members are in agreement with option 99 plus as described by Michael? I see nods around the table. Let's confirm that as the chosen option. Sorry, I missed you in this instance.
It's fine because I would agree with that.
Great. Okay. Fine. That's good to know.
Kathy's.
Sorry. Yes.
Thank you, Chair. Just a similar point as the last options. We will need a quality impact assessment for 99 plus.
Of course.
Because that's not been considered.
A really important point to make.
And it was just to confirm that from an engagement perspective, as this is additionality on an option that was consulted on, there wouldn't be a requirement for formal further engagement. But obviously we'll continue to communicate and inform our population as and when changes happen.
Thank you, Nikki, for confirming that. Let us go to the next service. Orthopaedics. Colleagues, anything you want to say before we kick into this?
It was just to reflect on yesterday and some of the conversation from a number of our planned care domains that, as well as considering the options you have on the screen here, for services such as orthopaedics and dermatology and urology to an extent, it's a mandate of changes that happened during COVID as well. So just to be mindful of that in our thoughts when we are discussing that. Within the addition for orthopaedics to bring your attention to is the regional orthopaedics programme is already active, and this is almost supporting the service mandate around continuing with that regional work as well, which I think is already through the regional joint committee programme as well. So it's just to flag those elements, if you like.
Great. So thank you, Ben. So the two things to pull forward from that is the fact that much of this is developed through that COVID experience in terms of where we are currently, and that the wider regional agenda is also something that we're engaging in terms of treatment at the current time with our colleagues at Swansea Bay University Health Board. Thank you very much. Very helpful. Mark, I'm going to come to you for an initial view.
Diolch, Derek. So I think what's important for us to describe is the success of what that the change that we made during COVID has led to. We've developed a unit in Prince Philip Hospital that meets British Orthopaedic Association standards. That's a high quality unit. The surgeons who were traditionally based in Pembrokeshire now travel to Prince Philip and patients that and operate on their patients there. So it's a significant success for us. And as we talked about, regional working has become another real positive for us, and our patients have significantly benefited from that, as have Swansea Bay patients. I think the difference here is about our ambition in terms of increasing activity at both sites, particularly Bronglais and Withybush. The unit in Bronglais is an excellent unit also and delivers high quality standards, but we have an opportunity to build on that also. And again, Withybush has moved towards the delivery of more day cases, and I think that again is something that we have the opportunity to build on. So I think the options are very similar, but the issue is whether we have the ambition to increase our volumes at both sites, and I personally would very much support that.
Thank you, very helpful. Yes, please, Andrew, anything you would add?
Just that operationally, we're obviously aware that from a waiting times perspective, trauma and orthopaedics is a particular pressured area for us. So in terms of us being able to deliver a sustainable service at a waiting time that is, as we heard yesterday, is still too long at the moment. We want to be much lower than 2 years, which is what the target is currently. But to get back to where we were before COVID, which was less than 36 weeks, we would need the ambition that Mark has stated around increasing activity, which is at the heart of the of option D, would be something operationally that we would want to be supportive of.
Yeah, great. Okay, I was going to mention the fact that I think you're right, Mark. I think the real ambition is to try and develop the service so it reduces those times and the waits associated with treatment. That would be the ultimate outcome for us in terms of this. The quality of the service, I think, is there. It's just expanding it in that way. Very helpful. Comments, colleagues? Maynard.
Doctor, is it just interesting that this is the one service where we're actually increasing activity virtually on all sites?
Yes.
And it's great to see that people are planning to improve the waiting list, as Andrew described, so that we get better care closer to home.
Point well made. I think it's a reflection. It's emerging demand, and how we anticipate this is going to be in the future as well. So very helpful. I'm not seeing a lot of questions or points that people want to make. Can I, on the basis of the conversation we've had, move us towards identifying which we think is the best option? Alex.
I just wanted to add a recap as well from the discussion yesterday. So when Leanne was here discussing orthopaedics, she mentioned that the element of the extended hours in Prince Philip of option 178 could also be something that's considered in option D as well. So the conversation you've just had there about improving the capacity of the services, that was something that the service delivery manager said yesterday. So I thought it'd be worth writing that down.
Thank you. Lee.
So just to pick out one key point is, a couple of key points, sorry. So Bronglais at the moment is not compliant to British Orthopaedic Association standards. So at the moment it's unsustainable on that basis. So what we are describing within this option, just I guess for board clarity, is a change in the way the service is delivered and the location of that. So that then would secure the long-term future of orthopaedic surgery at Bronglais because of an ability then to meet those standards, which would be really important. The second point I wanted to make is strategically we've talked about how we want to configure our services in the future and the role of each of the sites, and the opportunity to increase day case operation, for example in Withybush, is an example of that, where we see that opportunity to deliver more activity closer to home. So I think that's a really important point. And then I guess just to pick up on Alex's point there, I think I would support option D with then the addition of as demand requires, because obviously this will be subject to increasing demand over a period of time, we would then look to extend the hours in Prince Philip, which is the additional point in 178. But that would be part of an improvement plan over a longer period of time.
Of course. Nothing to add. Okay, so can I propose on the basis of what Lee's just said that we agree to option D with the additionality that we would explore the issue of extended hours based upon demand, patterns of demand, resources, and the necessary kind of business planning around that process. Is everybody comfortable with that? Great, nods around the table. Okay, let's agree that. Can we move to our next service, dermatology? Ben.
Sorry. Okay, just a quick recap around dermatology. Again, this is another example of a service where we've seen post-COVID changes, and we are seeing a significant amount of activity on the Prince Philip site. Some of the key aspects they've described and some of the challenges yesterday in relation to workforce are still there, but it was equally about the configuration and the mandate to support the configuration at the Prince Philip site around that activity, so they can optimise that and deliver that within the site as well. So what you've got on the screen here is that mandate to support consolidation of that service with looking at the capital assessment to how we can develop the service at that site to improve it further.
Great, thank you very much. We heard a compelling case yesterday for wanting to develop the consolidated service at Prince Philip for what seemed to be very worthy and robust reasons. Thoughts, Mark?
Dirk, so I think absolutely. I think this option is as we heard yesterday, very much supported by the service. Dermatology is a service. I've been here 20 years and we've never had a sustainable service. And we will only develop a sustainable service if we consolidate that and provide the right environment for clinicians to provide the quality of care that they wish to. We know that a business case will be necessary, but I think service consolidation, at least the hospital side of it, is very important. I think what's really good or an extra positive about this option is the delivery of services, maximising that in the community as much as possible, and also involving general practitioners in dermatological care, which is something that has happened, but I think we certainly need to build on that. So I personally would very much support option C.
Great, thank you very much.
That's just to confirm. I think that the community element of this is really important to note, because that will deliver. I think we will need a work stream that's looking at how we deliver increased levels of dermatology activity in primary care and community settings, which is completely consistent with the national direction of travel under the community by design framework, and completely consistent with the strategy we agreed for primary care and community services last month. So I would just emphasise that really.
Great, and indeed that gives me reassurance that this is aligned with everything that we're trying to deliver in the long term as a solution. Sharon.
Thank you, Chair. I agree with what Andrew and Mark have said. I just wanted to reference the conversation we had yesterday around building that multidisciplinary team around the service. And just to recognise that the enhanced advanced and consultant level practice, not just in nursing, but in allied health professions and in healthcare scientists. If we cannot recruit, then that will take some time to build. So we need some robust workforce plans around this option.
I think the devil is in the details. So we've got a suggestion here of a consolidated service. For me, that consolidated service is one that's not delivered through locum practitioners, but builds a workforce for us in the long term to sustain the service in a different kind of way. That's not for a moment questioning the expertise of locum practitioners in this space, but that is not going to create a sustainable service for us in the long term, as indeed we heard yesterday. Thank you, very helpful. Sarah.
Thank you, Chair. I'm absolutely supportive of the consolidation of services. One point that does concern me, though, is
the dependency on being able to deliver the nurse-led paediatric clinics on the cross-hands development. It doesn't feel appropriate that we are seeing children in an adult setting. And I think my question, I guess, is there, if we're consolidating at PPH, is there an ability to deliver some of those services at PPH whilst cross-hands is completed?
Good question. I'm not sure it's within the realm of what we are thinking about today, but I think it is a good question.
Yeah, if I may, because my question is cross-hands as well.
Yeah.
Very similar to the fact that at the moment cross-hands is being rescoped and developed, and there is no guarantee about the space availability to use this service. And it's what are the options if Welsh Government are not supportive of the capital required to develop the cross-hands.
Okay. Okay, good point. Yes, please.
Yeah, good points. So cross-hands, as board where we have been, we've had to revise the business case quite significantly, and we've had further recent dialogue with Welsh Government around opportunities to provide more than what we'd most recently proposed as part of the scale-down option. So that dialogue has progressed well. So I'm hoping I'll be able to bring some positive news back to board in due course around the plans for cross-hands. That said, I think Sarah's right, there's a timeline to delivery of that in any case, and as you say, may not a risk around delivery full stop. So I think if board are inclined to support this option, then I think we can work on the basis of cross-hands would be the preferred option, but is currently being provided out of Prince Philip, and therefore we can have a consideration around, through the implementation planning, what we might do in interim to try and alleviate some of those concerns.
Thank you, Lee. Very helpful. I mean, we know that cross-hands, much like Cardigan Integrated Healthcare Centres, are real flagships for us in terms of working differently with communities and working in the communities. So it's a vital step towards delivering our strategy in the long term that we continue to build on that. Although I appreciate the challenges of currently having that agreed and being able to move forward in that in a clear way. Anything you want to add, or
if I could? Diolch, Cadeirydd. So my point was a bit aligned to what Andrew has said. I think for dermatology, treatment of skin conditions, the vast majority of care of skin conditions takes place in primary care at the moment, not just in our area, everywhere in the community. And there's a huge amount that's about self-care. It happens to be one of those conditions that's particularly primary care focused. So in some respects, I think people would look at this and say, well, this is the special, we need to remember that this is the specialist bit of the pathway that we have to get right, because it kind of influences how the care of people with skin conditions, in primary care takes place. So one of my caveats, I think, should be for us that we maximise, we have a clear and coordinated and structured way by which we maximise the skin care within primary care and communities, as well as this agreeing to the option that's suggested here, option C, which I do support.
Okay, great. Thank you. If there's no more points, can I suggest we agree this option and to consolidate the service at Prince Philip, and that we continue to build and grow the services within primary care and the community? Great, okay. Let us move to our next service. Urology. Ben, anything you'd like to bring to our attention before we kick off?
Yes. So again, this, like the others, is about that mandate of change post-COVID and that activity. And we heard from the service yesterday, focused language that we have on the screen there around the urological investigations unit and developing that at Prince Philip and bringing elements of those services together. The proposed option includes Glangwili retaining its emergency offer, as it does now, and retaining outpatients day case diagnostic procedures at Bwrdd and bringing some of those aspects together at Prince Philip around the cancer pathways. And we heard about bladder and prostate cancer specifically yesterday from the service. And Withy Bush retaining, again, a significant amount of activity as well around outpatient stay case and diagnostic procedures. So it's looking at bringing together some specialist procedures within the service so that they can improve outcomes, but retaining services across the patch, but with a mandate to improve their offer on the Prince Philip site as well.
Thank you very much. Very helpful. Mark.
Dear Cadeirydd, I think probably Ben has described it all really. I think the issue is that centralised diagnostic hub, and we've heard from Mr. Saw yesterday that is something that is very common in other health boards across Wales. The volume of diagnostics in urology is incredibly high and is increasing, and therefore we have an opportunity therefore to be able to provide that. And providing that in a hub allows us to consolidate our services, consolidate our staff. And this does link to endoscopy, where one of the options is possibly about consolidating urological procedures in Prince Philip also. So I think this option does consolidate the decision we necessarily made during COVID, and supports the provision of acute care in Llangwili, and also will allow us to increase the amount of diagnostics that we're able to provide and ensure that patients on the single cancer pathway are treated within the appropriate timeframes.
Thank you very much. Andrew.
Just to emphasise that I think Mr. Saw, along with the team, have delivered a number of improvements to our urological diagnostic pathway over the course of the last 12 months, which has been a significant part of the improvement in access under the single cancer pathway that we've seen through the course of this year. The opportunity to develop the centralised diagnostic hub, as outlined by him yesterday, would be a really important next step then in terms of our sustainability for what is a very high volume and high activity service on that cancer pathway.
Thank you. Nikki, this is a bit out of the blue. Could you just remind us where the concerns were of the community in relation to this option?
Of course. I think the main concerns are that obviously where we're choosing to bring together the service is at the furthest east of our health board area. And so that's going to mean that more people are going to have to travel further in order to access the service. Alongside that, we did hear from some of our respondents that they would be willing to travel further if it meant that they could be seen quicker. There were concerns around the current length of time in terms of the cancer diagnosis was one of the things that we heard quite strongly from our communities, and also patient dignity was another of the key themes that was raised, again linked to longer travel times.
Thank you very much. That's very, very helpful. Very helpful. Colleagues, questions or observations? Bwrdd.
Ie, diolch yn fawr. A glywon ni y drafodaeth o just y sicrwydd ymlaen wrth, os i ni yn mynd lawr yr opsiwn hyn, bod dim un waiting list yn mynd i fod yn hirach a beth yw ar hyn o bryd, a bod pethau ni'n centralised diagnostic hub, ond just i sicrhau bod y service yn mynd i wella a bod ni'n mynd trwyddo gwaith yn ffastach na falle beth ni'n neud ar hyn o bryd, just cael sicrwydd na.
Diolch. Anything you want to pick up?
I think that is our goal, Rodri, to ensure that is the case, and this is the way I believe that we'll be able to achieve that.
So I think there's something about wanting to create a very sustainable service, high impact, high quality service, but to also address the issues of waiting times in that process as well. Yeah. Colleagues, any other? This is relatively straightforward, I say, with a degree of anxiety. Anything you'd like to add, Chief Exec?
Well, I suppose a couple of things. One is that, again we have an option where we've been influenced by the public. So there's, I suppose that's important for us to note again. I think the other point I wanted to make was around Rodri's point, which is this has to be about improvement. All of the decisions we're making today have to be about improved quality. And I suppose safety is only one of the elements of quality. You know, whether it be patient-centred, effectiveness, efficiency, equity, all aspects are important in the six domains of quality, and this has to be about improvement. We should be able to measure that over time, and I think part of our implementation plan will need to be clear about how we will measure the improvement.
Lee.
Just on a very quick point. So urology is clearly a very important part of our cancer provision, and urology is the service that we struggle the most with in meeting the cancer standards. So to Rodri's point, the whole ethos here is that establishing a urological investigations unit is the standard that people work to for the purpose of shortening that time to diagnosis and then obviously shortening the overall pathway. So that is the whole objective of designing the service in this way.
Very good. If there are no other questions or observations or clarifications, can I ask as a board that we agree option A? Great, okay, let's formally agree option A. Let's move to our next service. So we're moving into diagnostic services now. Sarah.
This slide highlights the key considerations that you heard yesterday from the public consultation feedback and the service dependencies.
Pull the microphone towards you.
The service dependencies for the diagnostic services, endoscopy and radiology. Some of the key considerations are accessibility, travel and transport, and the development of hubs.
Diolch. Thank you.
So I'll be introducing this one just as a recap. So following the discussion yesterday and the scoring from the option development group, what's been proposed there for the implementation and improvement phase is that option A, which would bring together the respiratory and urology procedures at Prince Philip Hospital and supporting that with an additional procedure room. So it would still have bowel screening and gastrointestinal procedures across the other site. But in the longer term, subject to development of capital and the identification of where a community site would be, developing a hub that would also be able to provide that additional activity. It's also probably worth noting that you've just gone through urology, but the option A is actually aligned more closely than, say, option B that we considered yesterday when going through them all, because it would allow for those urology procedures to be on the same site with that urological investigation unit.
Thank you, Alex. Very helpful. Mark.
So endoscopy is a service that's worked really hard over the past 10 years to reach national standards, and that, I think, indicates what a committed team that we have. The issue, as they described yesterday, is that we've seen every year a 5% increase in the demand for services. We have an increasingly elderly population, and bowel cancer, urological cancer, lung cancer happen more commonly with age. So really, to respond to that increase in demand, we need to consolidate our services and also increase the capacity that we've had. And as we described in the urological option, bringing together urology and also respiratory services, which is where our highest concentration of experts in respiratory diseases is on the Prince Philip site. This will allow us to provide a much higher quality and higher volumes to be able to address the needs of our community. I think obviously option B is a longer term option. We will see increasing demand. So I think in the The longer term, we will need to respond to that because we are going to reach capacity, or we probably almost certainly have reached capacity now.
Okay, thank you. Thank you, Mark. Andrew, anything you would add?
No, I don't think so, Chair, on this one.
Great, okay, thank you. I'm opening up for comment or views. Anne, and then I'll come to Lee.
Thank you. Some of the feedback yesterday was the concern with the public is travelling to have these tests done, mainly around bowel screening, because it's the biggest cleansing procedure beforehand. So this is why my gut says option A, because it's spread across our whole site at this time. I know with the fit testing and things like that, the procedures will get less and less, or more specific and targeted. So, thank you.
Thank you, very helpful. Lee, did you want to come in?
Yeah, thanks. So just a couple of points. Firstly, to note the line at the bottom, just for clarity. So, because of the options proposed, there is no impact on any of our emergency pathways or emergency departments. So it's important that that provision exists or will continue to exist on all 4 sites. We were told yesterday that the vast majority of the the endoscopy activity is gastrointestinal or bowel screening. The respiratory and urology are relatively small proportions of that activity. I agree entirely with Anne's point that option A, the benefit of providing bowel screening close to home, is important to us. So I would support that, I support option A. And then with regard to longer term, I think, as Mark says, we can anticipate further growth. So what we're describing here is trying to think ahead in advance of those projections as to how we would deliver that service. I think from what I heard yesterday and the discussion, I wouldn't have it as is set out there, where we have all of bowel screening in one location. And so on. I think what we'd be looking for is a community facility that provides additional capacity for endoscopy, and then we'd look to consider how that's delivered across each of the sites. But that would be a longer term plan in any case, so we would need to come back to that in terms of location and other considerations in due course.
I mean, I think that, so when that was raised yesterday, that was quite an attractive proposition to think in the long term about a specific site, largely, hopefully, based in the community, but offering that kind of facility, one or more sites. But you're right, it's a long-term prospect for us, not something that we need to address today. Phil, anything you would add?
Yeah, just two things. I mean, one is just to agree with Lee about the longer term point about bowel screening. I do think we can cover that as part of the business case development, because it may be that we don't want to restrict that to one community site. So I think that's one thing to reflect. The other point is that the public, just trying to continuously go back to what the public said, as well as what we heard from our staff. I mean, the public, there was a preference, I suppose, towards option C in some communities, particularly around Llanelli and in Pembrokeshire. But I do think we heard very compelling rationale for why option A would give our public the best advantage. I think it's just making sure that we're always considering that dilemma of what the hearing really carefully what our public have said, but the fact that actually the rationale for the offer for the public is much stronger, I think, for option A.
Great. I mean, yes, please.
Thank you. Just want to make it really clear that when we're talking about in option B for the medium to long term, a new site for bowel screening, not supporting that we're talking about one fixed site for the whole region. We're talking about community site, which pending there might be, like we have for breast screening, might be a mobile site or might be several community sites that operate in different, because we don't want to restrict bowel screening colonoscopies to one fixed site for the whole region.
I think that's a very important point, Ardiana. And I'm kind of thinking about as we look to the future, when we think about cross hands and other facilities, how we create multi-purpose environments that give us the opportunity to do lots of different clinical procedures and diagnostics inside that space. And I think we just need more information and more clarity on what that could possibly look like in the future. For the decision now, I think Anne's made an important point, which is let us bring this as close as possible to the communities that we are serving, recognising that it's going to change and the demand's going to increase in a compound way over the next few years. But let's focus upon that bringing together those endoscopic services at Prince Philip. I'm conscious much of the conversation yesterday was about an additional room, which felt a bit prosaic when we were thinking about the broad totality of developing this service. But actually, it comes down to sometimes some of those basic facilities, making sure that they're available and they're the right thing to do. So it feels to me option A is probably the best option for us to be choosing now. Notwithstanding your point, Lee, about the long term, will take us to think about endoscopic services being provided in communities in a different kind of way.
Nikki, just make a
point. I'll come to Lee and then I'll come to you, Nikki.
So I guess so I guess just for clarity, then it'd be helpful if board were endorsing the need to look at how we provide that additional capacity in the future, and then obviously we can bring that back to board in due course. Just for everyone to be aware, the option of a mobile facility was considered as part of the options available, but was discounted for various reasons. So I don't think we should get stuck too much on whether it's a site, multiple sites, or mobile. Or I think we just need to recognise at this point that we'll need the service to go away and assess how that could be delivered in the future, and then we'll bring that back to board in due course.
Helpful.
And that, as we heard yesterday, but just to emphasise that this is a service that we provide for Public Health Wales through long-term agreement, and they are the key stakeholders on this, and they're subject to national agreements, like JAG was referred to, the Joint Accreditation Group. So it is a process that will have several due regards in this.
Okay, thank you. Thank you for the clarification. Nikki?
The only thing I was just going to add in terms of the site was, as I talked through yesterday when we were consulting, we heard from our communities it was difficult for them to share their views around impacts on option B, specifically around not defining the location of the bowel screening site. So if further down the line there is a decision to move towards an option B, further engagement would be needed with our communities to understand impacts and potential mitigations linked to a single location or more than one site.
Thank you, very helpful. So on that basis, can I propose that we agree option A, but taking Lee's point, we also recommend that we come back to the question of the future delivery of this service in relation to meeting future demand, which will include further work around the potential site or multiple sites for delivering this service in the future. But I think your point, Lee, I think it's best developed within endoscopy, so they're best placed to decide how that might look. And as you quite rightly point out, Ardiana, it's something that will need to be done in conjunction and collaboration with Public Health Wales as well. Is everybody in agreement with that? Great, okay. And then let us move to our last service for consideration today. Alex, you look like you're going to say something?
I was just going to give a recap of radiology, if that was helpful.
Okay.
So again, the option for consideration here involves development of a radiology hub. So again, that site wasn't determined, and we said during the consultation we wouldn't know where that would be. But this option 103 is bringing together different options that we consulted on. So it's got that element of a hub. It's looking at improving the diagnostic radiology across sites, but also bringing together interventional radiology, and particularly that really acute stuff, and into where we'd look to provide those most acute services. Again, supporting the issues that the service raised around developing and protecting that workforce and allowing them to meet the inpatient demand against the unexpected demand as well. Similar to endoscopy as well, what we've said in these options, it would not affect emergency radiology access. So if somebody still turned up to one of our emergency departments, or somebody who's in the acute medical assessment unit in Prince Philip, they'd still have the ability to access that emergency radiology. So this is looking more at how we manage the expected growing demand in terms of that planned radiology service. So the option here looks at 103 in terms of the improvement and implementation. So that's bringing services together across those sites. And then when funding and a location were identified, the longer term would be developing that hub for more diagnostic radiology.
Thank you. Very helpful. Mark?
Claire, I think probably Alex said it all really. I mean, there are a lot of similarities with endoscopy, aren't there? Diagnostics is a very high volume service and can and should be provided as close to home for patients as possible. And so we should provide it in every county. Quite often the radiology services are provided in hospitals because of the equipment and the very expensive equipment like CT and MRI scanners, that whilst they can be mobile, they don't offer the same quality and ability to provide the high quality, the high volume that we do on each site. Also, there's a necessity for radiology to provide support for acute care. Glangwili has the highest volume of acute care and the necessity for inpatient interventional services, and that's why the services suggested focusing that in Glangwili. But as Alex has alluded to, that doesn't mean that interventional care won't be available on the other acute sites. It will be. So I think very much clinically I would support this option. I suppose the issue that we should call out is about the community provision, and it was described by the service yesterday about the services in South Pembroke, Pembs and Llandovery, and about the low volumes being provided there and the issues they have about providing that. So I think I'm sure that'll be disappointing to the communities if we choose and decide upon this option. But I think we've heard from the service about that is a field that they feel that that's the only real way forward.
Thank you, Mark. I wonder whether I'm just thinking about the South Pembs and the Llandovery sites where the equipment is kind of reaching that point where it's going to need to be replaced, or it'll just be no longer usable in terms of this. Because obviously those sites are really important to local communities. In the case of Llandovery, I think they actually bought the equipment. You know, the community is a vibrant, passionate, highly supportive community of delivering healthcare within its environment. They were instrumental in acquiring the X-ray technology in the first place. I'm wondering how we are mindful of those issues in terms of thinking about our decision today. Andrew.
That was one of the areas that I wanted to comment on and pick up on, because I'm a bit like you've articulated there. I'm particularly mindful of the conversations we had in Llandovery and the fact that the X-ray machine that we would be taking out of use through this was funded by fundraising efforts in that local community. So they're obviously very passionate about the service and access to a service there. The challenge we've got, as we heard yesterday, is that, and particularly now we've implemented the digital radiology system, is that machine is no longer compatible with our digital infrastructure in terms of reporting and our ways of working, and would need replacing very, very soon, which wouldn't be a priority from a Welsh Government perspective, I think, to fund based on some of the other ageing equipment we've had, which Mark has articulated there around CT and MRI scanners, for example. I think what I would want to be emphasising through this conversation, though, is that I know through conversations I've been having operationally, and in particular in the space of urgent care and urgent emergency care, is what future role Llandovery as a site might play in some of that urgent care model, and helping us to provide. I still think there is a really important role for Llandovery. It's not defined. I wouldn't want us to see, and I hope the population wouldn't see it as defined by this one aspect of the service. I'm really committed to wanting to have a conversation around how does it play into our wider urgent emergency care strategy, and urgent care in particular as part of the service model we're looking to develop, and as part of our integrated urgent emergency care blueprint that we've previously discussed as a board. So that's a conversation certainly I'd be keen to follow up on, and I know I've had some conversations with key members of the community there around them wanting to engage in a conversation on that as well. So I'd want us to be mindful of that, as you've said. I think the other point I just wanted to make then as well was around, I'm conscious that in this one, actually there's quite an impact for our staff that is described, that again came through quite strongly through the process and through certainly the conversations I've been party to. We would be asking them to move away from an on-call system into a shift system, which brings differences of reaction from different members of staff. I do think it's the right way forward, and we are an outlier in terms of the way we currently provide services. So a shift system is the way to go. But I think we, again, would want us to be mindful of the impact that will have on the perceived impact and the impact that our staff feel that would have on them at this point in terms of moving to that from where they are at the moment. So just something else to be mindful of, but I don't think changes where we would probably want to go in terms of decision making.
Thank you very much, really helpful, because it felt to me when we heard this yesterday, there was a tension between some members of staff welcoming the change to a shift system and others not. And I suspect that's the nature of organisational change. You know, you might agree a model, but actually enabling people to come with you willingly and intrinsically because they think it's the best thing is another step in the process of delivering change. So those things would need to be managed through in terms of any agreement or decision we would make here. But really important decisions, because we know the fragility around this service has very much been linked to the workforce. And the more that we can kind of think about how we can create a resilient workforce that feels it's delivering its best in the best way possible, feels to me the correlation between delivering a service that's resilient is absolutely clear. So I think there is something for us about thinking, you know, we can look at these changes in terms of the transactional shift towards delivering them differently, but it's fundamentally about the workforce that I think we need to be most aware of.
Yeah, just to say as well, I think just to emphasise what you've said, I think obviously radiology as a service is a real foundation of a lot of what we do, and it needs to be a foundation of how we move to a more 7-day-a-week model. Indeed. And that change in working pattern is going to be central to being able to do that in a sustainable way.
I completely agree with that. Colleagues, any questions or any thoughts? Yes, please, Hugh.
Yeah, thank you, Chair. There was a comment raised yesterday, and I wanted to kind of reflect on that today around not having invested in radiology for, I think, 9 years was the phrase used, or the period used. Clearly this is an area where demand is increasing very significantly, but I wanted to reassure the board that investment was made this year. I think we put 1.5 million in from our core funding, and if I recall, about 3.5 million from our own planned care recovery funding into radiology, with a further 1.7 million to come in next year. The reality, of course, is that's not keeping pace with demand, but I wanted to reassure the board that funding had been put in but also recognise the severe constraints within the service.
Thank you, Hugh. Very helpful. Colleagues, Anne.
Thank you, Chair. It's kind of reiterating what Andrew said. It's going to be the staffing. My gut feels that this is going to be the biggest staff shortage area that we need to build to get this up and running, because we're going into a 7-day service, because we're going to be going into rotas. It seems it's the least covered area, and I think we're going to have to look at grow your own and really advertising and recruiting to get into that field, to even start. I know this plan goes over a period of years, but it's going to take a bit of staff to get this into place. Thank you.
I think you're echoing the things that we think we need to think about carefully in relation to this. Thank you, Anne. Lisa.
Yeah, thank you. And obviously the workforce plan is critical for this one, so there is additional staffing requirements in there as well as change for our workforce. So absolutely we're part of that implementation plan.
Very good. Please.
Just a comment that we were told yesterday that we are the only health board in Wales that doesn't currently run a 7-day shift service in radiology. Every other health board has gone through the pain already, and it's us playing catch up in one sense.
Thank you, Maynard. Yes, please, James.
Diolch, David. I think what I'd add from my perspective, having worked through these options too, is the sustainability element and the safety element and the quality element are really quite significant. And it'd be remiss not to add in, we talked about the concerns around the West Wales challenge in terms of recruitment retention, the opportunity particularly to enhance the quality now, but also sustainably for advanced enhanced and consultant level practice across this professional group is something that we've been pointing out for a number of years, and I think this really adds to some of that challenge, reduces some of that challenge, I should add. Diolch.
Thank you very much. I mean, I think you're emphasizing, it came through in what Andrew said, and I think you've said the same. This is such an important bottleneck for us. If we can't get this right, it impacts upon our cancer diagnoses, it impacts upon our treatment across a whole series of fronts. We absolutely need to, this is pivotal. This is pivotal within the diagnostic space, as indeed endoscopy, for us being able to deliver all of our targets in relation to some of those broader treatments. Lee.
Thank you, Chair. So just 4 quick points then. So similar point to endoscopy, important to highlight that what we're proposing here doesn't impact on our emergency pathways, the emergency departments, that is retained on all the sites. Secondly, we mentioned Llandovery and South Pembrokeshire Hospital. As part of the implementation planning, I think we're going to need to do a detailed piece of work around the operationalisation of the change there if we support this option, not least any consequence for other activities that are currently going on those sites. In relation to the regional hub point, I think the same applies to endoscopy. It would be helpful, I think, if Bwrdd could endorse that as a direction of travel, and in order for us to commence a piece of work to assess how that could be delivered, but without obviously any specifics at this point in terms of where or in what form that would take, but just to anticipate that projected demand. And I guess just a final point, obviously a point that Hugh has made multiple times, in agreeing this direction of travel, what we're not doing is endorsing further investments into the service that, as has been noted, we are making that routinely anyway, but what we're not in a position to do is predetermine future annual planning prioritisation decisions. We're just setting out the direction of travel, which we can then build the service from.
Thank you very much. Very helpful. Nikki.
And it was just to add with that longer term option 103 with the regional hub. As we said with endoscopy, we didn't define obviously the location of that hub. So if once plans are taken forward, if that is something that the board agrees today to develop that, again, we'd want to go back out to our communities to understand the impact of wherever that potential location for that regional hub may be.
Okay, great. Thank you. Phil.
Yeah, a couple of points, then one question I had. So, as you said, Chair, that these services are absolutely intrinsic to the function of every other service that we provide, and that includes primary and community services as well as all of our hospital services. So it's important that these services work really well for our public, for the organisation. So I think we heard that compelling case, I think, yesterday for change, and also that implication around recruitment if we don't get this right for staff and we don't modernise. I think Andrew and Lee have made some important points about Llandovery. As Andrew said, the important role that Llandovery has to play in our system, but also Lee's point that we'll need a detailed implementation plan, which clearly will need to include any adaptation around Llandovery and flows. The point question I had, which I think I know the answer to, but just wanted to check with Alwena and Nikki, is that looking at what we heard from the public, there was a strong preference for option B, although there was views expressed across the spectrum of A, B, C and D. 103 is an adaptation of option A and B, and is enhancement, as I understand. But I was checking that was the view of our team, that we wouldn't need to go out to further engage. I just wanted to just confirm that.
Yes, that's the case, just with the exception of the location of the new regional hub. So when we look at option 103, in that top column, that doesn't include the regional hub, that wouldn't require further engagement. But when we look at the location of a regional hub, that would require further conversations with our population.
Okay.
Thank you, Nikki, for the clarification. Colleagues, any final comments? No. Okay. So on that basis, I'm suggesting we would support option 103. Given that there are a number of caveats related to that, Andrew, your point about Llandovery, I don't think we should see this as slightly separated from that. And are concerned to see a kind of workforce development plan built around this, the sustainability of this, because of the changes to providing a 7-day service and the shifts associated with that. I think that's going to take a bit of work to build that, and to engage everybody in that process. We need to engage individuals within this as well. I'm also mindful that we've started to think more about AI interventions and other digitalised approaches to delivering this service. I think that should feature as part of how we plan this service in the future, and how we build resilience into this service, which is deeply important for all the other services we provide as well. Anything I've forgotten or not said? Or any points anybody would want to add to that? No? Okay, then I suggest, if you're in agreement, we would support option 103. Okay.
With the caveat that Nikki has said that in the longer term, that when we're identifying a site, there would likely need to be further engagement.
Absolutely. Thank you for that. Can I suggest now we take a quick refreshment break before we move to our last section? Thank you for coming back so promptly. We're now going to move to our last item, which is the role of acute hospital sites. But before we do that, I just wanted to invite board members to offer any reflections, observations or thoughts on the process as we've engaged in it over the last day and a half. This has been an extraordinary board meeting. I wonder that we ever contemplated doing this within an existing board meeting, because it feels to me it's been an intense, demanding, and actually what I think a very helpful process to understanding how we plan for these services in the future. But I'm biased. So any views that you might have, or thoughts or reflections, be great. Neil, I'm going to come to you, and then I'll come to Mark, and then Eleanor.
Thank you. So, as a relatively new member of the Health Board, I think it's been reassuring to go through this process over the last 6-7 weeks for me personally. I mean, I have been involved in community health before, but I think on reflection, we can sit back and say the decisions have been taken with consideration. They've been clinically led. They have been informed by community. And I think it does show real intent and a future-focused direction for the Health Board that gives me reassurance and comfort that it's demand-led, it's looking to the future. In some cases, we're seeing additionality. So we're seeing that services are, in fact, not being downgraded, which has been the narrative that has been in the public domain. But I think there's actually a very positive story here about what we're trying to do for the future population health and needs. And I think that in terms of how we continue with this, there would be some challenges and some things that I would like to keep my eye on as an independent member, which would be around, and I know we've made these commitments this morning around transport and transfers. I think there's something around myth busting and continuing to work with our communities to have an ongoing conversation with them. And I think there's something in, well, as I mentioned at the beginning of today, around the deal, which is rebuilding trust, getting the basics right, making sure that we're delivering on our what we're proposing to do, and ultimately working more and more in the community space. So I think we've got a great opportunity from today to reshape a narrative around this is actually future focused. It's not about cuts, but it's actually been approached with some real thought, consideration, and I think we've come to some good decisions over the last couple of days.
Thank you, Neil. Very helpful. Mark.
Diolch yn fawr. I just want to reflect on the clinical engagement that we had yesterday and we've had during the whole process. And I want to personally thank the clinicians for giving up their time and being so engaged. And I think it sets a really good foundation for us as an organisation going forward to show that clinical engagement. Quite often in the National Health Service, there's an understanding the friction exists between clinicians and managers, and I think we saw that wasn't the case yesterday, that everybody is aligned and everybody is aligned on delivering the highest quality and safest services for our patients. So I think we definitely demonstrated that.
Thank you, Mark. Very helpful. Eleanor and then Michael.
Diolch, Cadeirydd. Diolch I pawb sydd wedi bod yn rhan o'r broses I helpu ni cyrraedd at ble ni wedi cyrraedd heddiw. Y tîm cyfathrebu, y clinicyddion, a pawb sydd wedi dod yma a dangos ei profiad yn y maes. I really want to thank everybody that got us here. It's been an intense 2 days, but ones where we've had very focused discussion, and we wouldn't have had that focus without the work that the team have done on the analysis to get us here. I think it's been managers, communications, community, and I think something Neil said struck home. This is about looking to the future so that we can paint a proper picture of what it looks like for the people that we serve as a board, and it has put health, quality, safety, well-being, all of it at the heart of what we do. And I'm really impressed with the contributions that we've had in. I think it has been It's been a long couple of days, and I'm delighted to see I've seen colleagues concentrate throughout, which is not easy in these circumstances. We could never have done it in a board. It had to be an extraordinary meeting, and thank you for your forbearance with that. And thank you to Neil for chairing us through it as well. It's not an easy thing to chair for a day and a half going through. So I just hope I believe we've come to the right decisions, and it's now time to explain that and explain the next steps in this journey to the people that we serve.
Thank you. Thank you very much, Eleanor. Michael.
Thank you, Chair. I find this has been a very worthwhile and well-run last 2 days. I want to pay particular tribute to those who produced the slides we've been working off, which I've some very complicated issues there, but I think they've been, my personal view is they're very user-friendly as I describe them, and I think there's a great credit for that. I just want to echo something which was said at the very beginning of the meeting yesterday about the need for the transport strategy. I come back to that, and I want to say something I've pushed many times. I'd like to see us not lose sight of that as a parallel, important piece of work which has to start tomorrow, basically, and maybe that coming back to a board meeting shortly about how that is happening, because I think that would that's something that has to be done, and it has to be done now in parallel as we go forward with the moving these other decisions through the system and taking them forward.
Thank you, Michael, and I would absolutely support that view. I think that's absolutely what we should be doing, and we will come back to a board in the future and address it there. Andrew.
Yes, diolch, Gareth. If I may, I just wanted to take the opportunity to publicly thank my teams yesterday for the way they approached the session, the way they presented and dealt with the questions. I know coming in, we might not think so because we think we're a friendly bunch, but I know for a number of them it would have felt like quite a daunting experience coming into this room in this setting to talk about some of the difficult issues that we needed to deal with yesterday, but I was very proud of all of them in the way they handled that, and I hope that the way they've dealt with that has helped us in our deliberations and discussions as well. And also, in thanking them, I also want to make sure I thank, obviously, Ben, Nikki, Alex, Sarah, Yvette, everyone that's been involved from all of your teams as well, and Leah and Owen's teams, in terms of their support to my teams in getting to that point and getting us to today, and echoing the points Michael's made around the quality of the documentation, everything we've been working off. So it's just an opportunity to thank them publicly.
Thank you, Andrew. Well said. I'm going to come to Sharon.
Thank you, Chair. My apologies. Apologies I wasn't in the room with you. I think it's my loss, but I completely concur with what the colleagues have said, and certainly with Neil in terms of this provides us with the necessary direction of travel. I think our discussions have illustrated that future success will depend on safeguarding quality, focused multidisciplinary team working, and ensuring that the changes do not widen inequalities for our rural communities. And going forward, I think as services change, our governance must remain vigilant with clear quality metrics, early warning triggers, and strong patient experience feedback loops, which has come across in every conversation that we've had really over the last 2 days. So, diolch yn fawr.
Great, thank you very much. A point well made. I think we need to remain vigilant as well. Can I... yes, please, Ardiana. Alwena.
Diolch, and thank you, Sharon, also for mentioning part of my point that we must be vigilant that we do not increase inequalities in our population. Also, as a reflection, it's been really positive and reassuring to hear clinical managerial, our providers, to talk about how they're developing service, and that we keep at core that embedding those preventative elements of all the 9 services that we've discussed is not an added afterthought, but it's a core recognition and embedment throughout those service developments. It will not slow the development and delivery of clinical services plan, but it will ensure that they are sustainable. And I also wanted, as a reflection, to just add on the very relevant point that Michael made, that we must come back to the transport, but we must come back to the access issue. And access is much wider than just transport and than just travel to a clinical service. Access is the appropriateness of the clinical services, which we had several reflections, for instance, how the appointments are made, how culturally sensitive our services are, and how person-centered they are. And that will enable us to have quality service, and that we monitor actively both the patients' outcomes, but also the reduction in inequalities in these services that we're providing. Diolch yn fawr.
Thank you, Adriana. Well made. Yes, please, Alwena.
Gai ymestyn diolch ychydig ymhellach, os gwelwch yn dda. Mae'r broses o gyrraedd i heddiw wedi bod yn 2 flynedd hir i nifer o unigolion. Rhai ohonyn nhw bellach ddim yn gweithio ar Bwrdd Iechyd am bod nhw wedi symud ymlaen i gyfleoedd eraill, ond mae yna gyfle i ddiolch iddyn nhw. Yn naturiol, dwi'n eitha balch o'r gwaith mae'r tîm cyfathrebu a'r tîm gysylltu wedi gwneud gan weithio law yn llaw gyda tîmoedd clinical a yr tîm o dan Lee. Ond mae rhai unigolion hefyd wedi bod yn rhan o'r broses o ddatblygu yr opsiynau, a rheini'n unigolion o'r grwpiau cymunedol sydd wedi bod yn gweithio law yn llaw ni. Mae gennym ni gynrychiolaeth o'r grŵp o achub gwasanaethau Bronglais yn yr ystafell. Fi oedd cyfeillion o Sosban yn yr ystafell hefyd, a maen nhw wedi rhoi oriau o'i amser personol nhw i fod yn rhan o'r broses o ddatblygu opsiynau gyda ni law yn llaw yn ystod y misoedd ar 2 flynedd diwethaf. Felly diolch y galon iddyn nhw. Hefyd, dwi'n ymwybodol bod Alison o Llais a Donna o Llais ddim yn gallu bod efo ni heddiw, ond mae cyfraniad nhw o fod yn heriol yn gadarnhaol heb i ail. Maen nhw'n yn cadw ni ar trac ac yn gwneud yn siŵr bod ni'n datblygu gwasanaethau gorau ar gyfer ein cyhoedd a'n staff. Felly mater o ddiolch i aelodau'r gymuned yn staff ni ag i Llais am fod yn rhan o'r broses hir yma, ac am fod mor agor yn ei adborth mewn ffordd gadarnhaol sydd yn alles ein cleifion wrth galon bob dim. Felly diolch y galon iddynt.
Diolch. Thank you, Alwena.
Sori, un rhan arall a dwi heb gofio ydy i ddiolch i'r cyfieithydd, o'r Gymraeg i'r Saesneg, ond hefyd yn cyfieithwyr BSL sy'n ar sgrin. Dyma'r tro cyntaf i ni wneud BSL fel rhan o'r bwrdd. Dwi'n credu mai dyma'r cyfle cyntaf i ni wneud o ran y Gymraeg mewn cyfarfod o'r bwrdd sydd ddim yn gyfarfod blynyddol. Dwi'n gobeithio fyddwn ni'n parhau gyda'r elfen hyn wrth fynd ymlaen. Ond diolch y galon iddyn nhw ar y sgrin. Mae wedi bod yn wych gweld bod ni'n mynd yn fwy cynhwysfawr.
Diolch yn fawr am cofio hwn. Very good. Okay. I'm going to come to Phil and I'm going to offer the last word.
Yeah, and I'd reiterate my thanks to the team. I think the information that we've had has been prepared so professionally, so well done to the TPO members who are here, and also to Nikki and our clinical leaders and managers who presented yesterday. Huge thank you to them all, and to members of Protect Bronchitis Services and SOSPAN who've been here today. I know you've travelled a long way to be with us, so thank you for that. One point particularly was in response to Michael's challenge, I would say, and a few others, Neil as well, around transport. And I think as an executive team, we need to take that away to see what would be helpful that we could bring back around transport in terms of a transport strategy. So I'll work with Lee and other colleagues to consider how we would bring something to board or through the committees in due course.
Thank you. Alan, I was just going to say, you raised Plyce's role and their contribution to just the way in which this has developed. Obviously, Alison was here yesterday. She wasn't well. and she couldn't make it today. But I think we did value her contribution yesterday enormously for helping us steer that path that I think recognise the importance of patients, communities, people who we deliver our services to. So I acknowledge that. My closing comment would be, I suppose, I often think the quality of a really good meeting is that we arrive at a different place from that which we thought we would have. And I think that's probably where we've got to today. There's been nothing predictable about our outcomes. In fact, if we look at the decisions we've made, at least 40% of those decisions are based on community recommendations, which I think is significant. You know, so we haven't come in here with a prescribed formula saying, regardless of what other people think, this is what we're going to do. I think we've demonstrated the fact that we've listened and we've incorporated those ideas, we've thought about them, we've co-productively brought them into a space where we can start to consider that as a future way forward. And I think that is a really exciting, dynamic part of the process. And like others, I'd like to thank the community for engaging with us. It's occasionally been blistering and challenging, but equally joyful. I think some of the conversations I had with individuals during the consultation were absolutely energising in terms of what they wanted from services and how they thought those services should unfold in the future. And I'm hoping we can continue to have that narrative and dialogue. So in as much as this has been an extraordinary experience, both the board meeting and in terms of where we've got to, I'm hoping that what we do is set a template for how we want to think about our service configuration and reform in the future, that bringing to it this studious, thoughtful, considered, as you said, Neil, a kind of mindful approach to these issues, I'm absolutely certain will help us deliver the right outcomes in the end. We could, one of the observations in my head a few days ago was that we could just sit on these services and allow them to continue in their current form. But we can't really. We cannot. As a board, we have a duty to ensure that we support the evolution, reformation and development of these services in the interest of the patient population. And that will not always make us popular. That will mean sometimes we have to make difficult decisions that some individuals and some communities might not like. But I want to emphasise, we do it with the best of intention and heart. We do it because we think these are the right things to do and the right way to develop our services. And in that degree, we are fully committed and confident that we're doing the right thing. Thank you for that. Thank you for your contribution. I'm now going to hand over to Lee.
Thank you, Chair. So the final part of the session is looking at the role of our acute sites. So as was mentioned yesterday, this wasn't something that we set out to describe at the outset of this work, but it came as a natural conclusion, if you like, of all the options that have been developed in the work through the process. But just take us back to how this fits within our strategic direction. So we agreed at board in January a refresh strategy with a mission statement of healthier lives well lived, and within that we set 4 strategic objectives: thriving teams, healthier communities, great care and positive futures. You can see, I think, through the process we've gone through the last 2 days that we are endeavouring to progress in each of those objectives so that we can deliver our overall strategic ambition. What we have had quite a lot of discussion on in through the consultation and around it is what this means for the individual sites. Now, it's quite difficult to do that at a very detailed level without going service by service, and of course we've done that for the 9 services now. But what we did think would be helpful would be to describe an overarching framework, if you like, for how we see those sites developing over the medium term, recognising that we've got our long-term ambition set out in Healthy and Winner West Wales. So what we did was consult on this, and we covered some of this yesterday. What I think is key to highlight from this is that all 4 sites will provide a very important role in the future delivery of healthcare services for Mid and West Wales. No one site is more important than another, and what we foresee is that they will all have their distinct functions to support the needs of our population. So all sites in that case will be vital to delivery of the medium term, and they also will all be busy. So all the sites that we go, if you go to them today, they are very, very busy, active sites, and we foresee that continuing for the medium term. The other wider context is we have an aspiration to shift our model of care to one of prevention and primary care, and obviously community services. We talked about that at the last board as well. So sitting behind all of this is a wider aspiration to reduce the need for some of these services over time, whilst at the same time improving the quality of that care when they are required. We've highlighted here some of the factors that have come through the discussion, not least the provision of services in communities, the use of digital, transport and transfer arrangements we've referenced a lot in the discussion. But the critical, I guess, conclusion from this is that the 4 sites are not and will not be islands within Hywel Dda. They will be a connected system, a network model that delivers the services that patients need in a variety of different ways, and therefore we've found a form of words that tries to express that, which we tested with the public. So what I'll do now is hand over to Alex, who's been looking at the decision making through the course of the day and the alignment to the descriptions that we've got on the screen. Thank you.
Thank you, Lee. So I think where we've got to from the decisions today is that actually the statement that we went out to consultation with around the roles of the hospitals is probably still largely unchanged, and is still there. So, for example, at Bwrdd we discussed providing services it currently does, but with some specialities or parts of the care that's provided being delivered at other sites. So in particular, in the discussion today, we talked about parts of stroke no longer being provided there, but you'll still be able to access that emergency care and the rehabilitation and that idea that's proposed. And a strengthening as well of the emergency general surgery service in the future. So there's still very much almost a status quo of Bwrdd in terms of the role it provides. Glangwili, the decisions made around emergency general surgery and stroke there kind of emphasise that strengthening of the acute role it plays, while we've looked at some of the inpatient parts of urology and the planned diagnostic work of radiology going to other sites. So it does match that description that we put out during the consultation. And then Prince Philip, so today we discussed around the role it plays regionally, providing that orthopaedics role, as well as some of the other opportunities to develop regional working. So if you've got hubs of services developing there, what that could mean for the future. And then with Withybush, I think we heard quite strongly throughout the consultation that people were concerned around the erosion of services. Today, the decisions made around emergency general surgery and critical care very much retain, as we described in the consultation, that immediate access to emergency care. So people will still be able to go there. They'll be able to use those SDEC services, the treat and transfer, so they get seen by somebody right away. But if they are really unwell, they are really ill, that we'll be able to get them to somewhere where they can provide that care. So I think that the statement that we put in the consultations reflected still within the decisions made. And I suppose the question that you posed earlier, Neil, around what this means going forward and yesterday as well. So we know that Bwrdd Hospital developed a strategy shortly after the 2018 Healthy Mid and West Wales. This sort of layout supports hospital sites to develop or refresh those strategies, but also support our longer term planning processes and IMTPs. If we've got a way of setting out, well, what do we expect each of our hospital networks, sites to provide in that network to support that future planning and, as you said at the start of the day, not make unhelpful precedents in decision making.
Very helpful, thank you. Does anybody want to add anything to that? I mean, for me, it's interesting, isn't it? Because one of my observations over the last couple of weeks is, have we been clear as a health board what we think each of our hospitals will be offering in the future? And we might understand that clinically, because we understand the complexity of those services, but I'm not sure patients have an appreciation of what those buildings and those services they're offered look like. And there's something for me about trying to kind of shorten that gap between what we're saying, but actually how we paint that picture of what that particular facility will be doing and how it does it in the future. I would want that. I would want to know that Withybush was going to be this kind of facility and that we were working towards that. And I would want to know the same about Bronglais, Glangwili and Prince Philip. One of the dangers of the CSP is that we iterate these services so bit by bit and practically and operationally, because that's the best way for us to be able to manage this in a complex system. But what we end up doing is kind of losing that sense of what is the coherent picture of each of our hospitals as facilities, and how do we communicate that best to the patient population and the wider community to give them assurance that these hospitals are everything you've said they're going to be, Lee. They are vital, they are deeply important, they are networked across the organisation, and they're delivering healthcare that we can be truly proud of. I think that's really important, and I've not yet seen that picture. And if I can't see it in my head, patients can't, or communities, I don't think. Yeah.
Yeah, so there was one point I wanted to make, actually, just about, sorry, microphone. There was one point I wanted to make about the four descriptions we have. A non-Bronglais hospital, I just thought that we might want to tweak it, and I put it out there, that around tweaking it slightly, that providing services it currently does suggests that we aren't adapting, enhancing, improving, and I think and networking. I mean, I think what we have heard over the last 2 days is that we are expecting advancement, not only at Bronglais, across all our sites. It's just in the Bronglais description, it does sound rather like it's sort of staying as it is, whereas actually that is not what we've described. So I would perhaps argue for providing, we probably need to get the wording right, but I would suggest we need improvement or enhancement and networking in that box. But otherwise, I think it's helpful to have this description because of what you said.
Of course. Any other views? No? Okay. I'm just wondering, is there anything, Lee, we need to take from this now? Or?
So, on the basis the board are content with the general thrust of what we were describing, noting Phil's point, we can think about the specific wording. I think probably to build on your point, then, Chair, the next step would be to further describe the future roles of the sites, and we can think about how we do that over the coming months and engage the board on that as required.
Great. I think that would be really helpful. I think that takes us back to where we started the conversation yesterday, which is us being aware that these hospitals will transform. They will transform over the next decade, as will every hospital in the country, and we need to be at the front of that, not kind of being pulled from the back. We need to be at the cutting edge of that for our patient population across Wales. So thank you very much for that. I think that's been very helpful. Thank you, Alex. I'm going to close this part of the meeting, and before we move to our item on regional cellular pathology. Before I do, I just want to thank Claire, who has stalwartly kept a minute of everything that we've done over the course of the last day and a half, which I think has probably been Herculean in terms of capturing the detail. I know she's provided me with that detail, which I've already found very useful, but I just wanted to thank Claire.
Thank you.
And indeed the team we haven't seen outside who are helping to support this service as well. So thank you very much. Great, let's close this item. Just a minute, and then we'll move into regional cellular pathology.
Chair, just to declare an interest on the papers, although they are, these are being discussed in the public domain, just to say that I will not be participating in any conversation because of the declaration of interest being an employee of Swansea University.
Okay.
Yeah.
Maynard?
Also, I have a minor in Swansea University as a member of the Information Governance Review Board for SAIL.
Okay, thank you, Maynard.
I also need to declare an interest in the sense that I have an honorary chair with Swansea University.
Great, okay. Anybody else need to fess up? No? Okay, thank you for making us aware of that. Very helpful. We acknowledge, Chantal, you can't engage in this conversation at this point.
Chair, just for the minute as well, we have had a conversation at the Regional Joint Committee and in committee due to the commercial sensitivities regarding this item, and Chantal was not present at either of those, so just the public record.
Thank you. Thank you. Okay, so can I just first of all confirm, in terms of our governance, apologies?
Yes, Chair, so we've apologies from Winston Weir, and we have apologies today from Alison Thomas, who is poorly, as you've already referenced, from the Clyce, and also from Michael Gray, our Associate Board Member Chair.
Thank you very much. I'm going to take us to our first item, which is the Memorandum of Understanding for the transitional approach to the Regional Cellular Pathology Service. This is for approval. Andrew.
Diolch, Cadeirydd. Colleagues will recall around a year ago, last March, we considered, along with Swansea Bay, and approved the the draft transitional MOU for a regional pathology service. As your colleagues will also be aware, over the last 12 months, there's been a lot of work that has progressed that has both changed the scope of that programme, and therefore we've taken the opportunity to update the Memorandum of Understanding to reflect that change in scope and some of the changing dynamics around it. So, for example, the fact that we now have a regional joint committee infrastructure, not an ARCH programme infrastructure, for example. So this is being brought today. It's being considered by both health boards and will be approved by both health boards. I think it was considered by Swansea Bay earlier on this week and approved. So just by way of an update on that, and so I'm asking us to consider and approve the changes that are outlined in the paper, which are detailed. And just before I finish, I just wanted to say a special thanks to Charmarie James for all the work she has done from a legal perspective in supporting the work on this across both organisations as well, because it's not been a small task.
Thank you very much, Andrew. We'll endorse that. Thank you to Sian. Colleagues, are you happy to approve the redrafted Transitional Memorandum of Understanding? Yes, I see nods on the table. Okay, let's consider that approved. And then Regional Cellular Pathology Preferred Laboratories Site. This again is for approval. We'll look to Lee.
Great. Thank you, Chair. So over the board members will be aware that we've been working for a number of years with Swansea Bay on the development of regional pathology services, and within that we had a proposal previously to develop a centre of excellence at the Morriston site. That was a very substantial capital investment proposal, in excess of 130 million by the time we got to the point of taking that to government last year. In January last year, we had direction from Welsh Government that couldn't be prioritised within the capital programme available. So board members will recall we commenced a piece of work to look at what could be delivered at a reduced cost to deal with our most significant estate and workforce risks. If your board members will recall, we've had significant risks associated with both the estate and workforce delivery in pathology services for some time. I've chaired a group regionally to look at the potential options for that. And in September, we brought an update to board recommending 2 sites for further analysis and assessment. They were Pentre Awel and Sandringham Court. A 3rd site came to our attention in November, which we incorporated into the process. Over the past few months, we've done a very detailed assessment of each of the 3 sites, looking at the technical implications, so things like the mechanical engineering implications of converting those buildings to a pathology laboratory, and also looking at the non-technical aspects, so the impact on staffing and aspirations to become a centre of excellence and so on. We held a workshop at the beginning of the month to look at all of that information in a great deal of detail, and the workshop came to a unanimous view that the Bay Campus site was the preferred location. In order to progress that, we need to submit a proposal to Welsh Government, which is included within the papers, what we're proposing to include, what we're proposing to present to Welsh Government, and obviously is subject to capital support from Government, as well as potentially revenue support from the health boards, recognising the wording specifically within the recommendation in relation to that. We did take this through the Regional Joint Committee on Monday, and as we mentioned, we've also taken it through the Swansea Bay Board on Tuesday, and it was supported and we discussed it in committee yesterday. So we're recommending to board that the preferred site is endorsed, and you support the submission to Welsh Government. Thank you.
Thank you very much. Colleagues, thoughts or observations? No? Hugh.
Yeah, Chair, thank you. I think Lee has covered much, but I just wanted to re-emphasise, of course, there is a revenue contribution required, which Lee mentioned, and as the full business case is developed, we need to think about options to address that, the number of options that we've got available to us, but we do need to be very clear on that position, and not least because there is an added risk here in that this is a regional development, so we need to do that in cognizance of partners as well.
Diolch. I completely agree with that. Yes, please, Eleanor.
Thank you. Just a reminder, our starting point of this is our severe concern over the conditions of the Cellular Path Lab in Hywel Dda, in Glangweili, and the risk of not doing something is probably greater than the risk of doing something. But having looked through these plans, we supported it at our Regional Joint Committee, and I am very supportive of the process that's been through and of the recommendation as is.
Thank you, Eleanor. Very helpful. If there's no other comments, can I suggest that we approve the recommendation? Great, okay. Thank you. Let's record that. Any other business? No? Oh, yep.
Well, I wanted to let the board know that I've had a letter from Welsh Government this morning to let us know that we are being de-escalated as an organisation around our cancer performance from level 3 to level 1 because of our sustained performance above 63% of the cancer target. So a big thank you to the teams who've made that possible. It's a significant achievement, and of course not all organisations are being de-escalated. So that doesn't take away from the fact that 63% is not the target. We need to, in fact, one of the conditions in the letter is that we continue to improve. And of course, that is certainly our plan to do so.
Great, good news. Good news. Thank you, Phil. And well done to everybody who's contributed to that. Lee.
Thank you. So on just a different point, taking us back to the the main purpose of the meeting today. We didn't cover next steps particularly, but it was set out in the slides. So hopefully that's self-explanatory. But what I did want to just highlight is that we have undertaken impact assessments. These are all available on the consultation website, and we've considered within that socio-economic duty and other factors, and there will be further work for us to do on the impact assessments following decision making today. So I just wanted to clarify that point for the board.
Of course, and in many ways, well, indeed, I think that's very helpful. Thank you for clarifying. Great. If there are no other comments or suggestions or observations, I'll close the meeting. Thank you very much.